IPF takes your patient's independence.
IPF takes away precious moments forever.
But it doesn't have to be this way. You can't stop IPF, but you can slow its progression.
Making an early diagnosis is key. Anti-fibrotic treatment could extend your patient's survival. Treat immediately after diagnosis to preserve all that is possible in IPF. Act now.
Because IPF does not wait.
Appreciate the kind invitation of Boehringer Ingelheim for me and my deep friend and colleague. Actually, he is my brother, Professor Tariq Safat. As you know, interstitial lung disease is a chronic progressive disease, as mentioned by Professor Tariq. And up till now, there is no definite causes for interstitial lung diseases. The management is controversial. Even the causes, most of the causes of the interstitial lung disease are unknown, but sometimes we have some data about the possibility of some underlying cause of this disease. So that we hope during this session or sessions, we can have some answers for many questions, possibility of any new management of the disease. We will start our program by inviting our colleague, Professor Yusri Aql. He's Professor of Pulmonology at Cairo University, to give his presentation. Please, Professor Yusri Aql.
ميري، هو في مشكلة في الزوم؟ اوكي. لا مش عارف، سامعنا يا دكتور يسري ولا مش سامع؟ مش عارف. هل هو اوديو دلوقتي ولا؟
السلام عليكم ورحمة الله وبركاته. هل صوتي مسموع؟
ايوه مسموع يا دكتور يسري. طارق صفوت معاك والاستاذ الدكتور محمد عوض.
ده كبير ازاي حضرتك؟ انا سامع صوتك بصعوبه جدا.
الصوت وحش؟
صوت حضرتك انا سامعه بصعوبه شديده.
بصعوبه شديده.
انا ما اعرفش صوتي انا مسموع كويس ولا لا.
انت صوتك كروان يا يسري.
اعمل بيه؟
صوتك كروان كروان.
الله يخليك.
بص يا يسري،
ازي سيادة الكبير وسلامي لاستاذنا الكبير الاستاذ الدكتور محمد عوض تاج الدين وشكرا لشركة برينجر على تنظيم هذه الدعوة، هذا المؤتمر يعني النهارده، ودعوة كوكبة في الحقيقة من الأساتذة الأفاضل لحضوره يعني. وأتمنى إن شاء الله نبقى جود ميتنج إن شاء الله.
You can proceed يا دكتور يسري بقى عشان التايم بس. عشان التايم.
اوكي. ان شاء الله you will try to be on time ان شاء الله. you'll start يعني with some cases كده for warming up our brains. The first case is a male patient 63 years old complaining of progressive exertional dyspnea and dry cough of 2 years duration, but the patient has Raynaud's phenomena and arthralgia. He's non-smoker, no history of definite exposure, no other systemic affection. On the right side is the HRCT of this patient. And as we see, it is a reticular pattern with some areas of honeycombing and traction bronchiectasis. So this is UIP. The question is, next slide, please.
هو انتوا شيرنج ولا هو؟ انتوا اللي شيرنج؟ يسري، دكتور يسري، يا ريت تعملوا ميوت ان صوتك مش مسموع.
انا عاوز السلايد اللي بعد كده، معلش اللي جت فيه غصب عني كده. صوتي مسموع مش كده؟
لا صوتك كويس قوي يا يسري دلوقتي،
بس انا مش شايف السلايدز.
هو السلايدز من عندكم ولا من عند الدكتور يوسف؟
هي تشيرد من عندكم، من المصدر من عند ميري.
دكتور يسري، انت اولا مساء الخير وازاي صحتك؟
ازي حضرتك سعاده البيه؟ ازي حضرتك يا بيه؟
الله يخليك. انت مش قدامك كمبيوتر يا يسري؟
نعم بيه؟
مفيش كمبيوتر قدامك؟
لا انا بتشير من على اللابتوب، من على التليفون للاسف، لاني ما عنديش زوم على الكمبيوتر، انا حطيته على التليفون. بس كان في شغال، كان البرزنتيشن شغاله، ما اعرفش دلوقتي ما
هي شغاله. انت جيت عملت كيس 1 وبعدين بعديها كان في كيس 2 قبل ما نخلص كيس 1. فحضرتك انت امال بتشوف شايف اللي هم عاملينه هنا ولا مش شايفه؟
يعني المفروض ان هي المفروض ان ميري عامله تشير انا بعت لها البرزنتيشن وهي عامله تشير.
هقول لك حل يا دكتور يسري، هقول لك حل سريع. بعد الكيسز دي في برزنتيشن ولا ما فيش؟
في بس مش قدامي برضه البرزنتيشن. هي كل شير من عند ميري.
ممكن حضرتك تفتح السلايدز من عندك وانا اي ويل فلو معاك، همشي معاك على الفلو. بس افتح السلايدز من عندك، do not share please. I will be sharing من عندي، بس حضرتك انا هبقى معاك في الفلو بتاع السلايدز.
اوكي. So this is the first case, and as we see on the right side of the screen, the HRCT of the patient, which shows the classic UIP pattern, is a peripheral pathology with definite center to peripheral gradient and the craniocaudal gradient. The question is, what is the most likely diagnosis? Is it idiopathic UIP IPF? Is it NSIP? Is it fibrotic HP? Is it connective tissue disease related UIP? Is it idiopathic UIP with some autoimmune feature? لو رجعنا للحالة، لو رجعنا طبعا للراديولوجي is UIP definite UIP. and لما نيجي نبص على سي تي لازم نبص على الانتاير ثوركس وليس اللنج itself. لو احنا بصينا لتحت في القط اللي تحت على الشمال في second slide هنلاقي ان في dilated esophagus. The presence of dilated esophagus, the presence of Reynolds phenomena, arthralgia هياخدنا لدنيا ان ده connective tissue disease related UIP. So في حالة زي دي لازم نتعاون مع حد بتاع روماتولوجي عشان نبيك up the correct diagnosis. Is it UIP, IPF? Is it UIP with related connective tissue disease, scleroderma, I mean, or it is UIP with some autoimmune flavor. The second case, as we see, the female patient is 40 years old, complaining of progressive exertional dyspnea, the same symptomatology of ILD syndrome, dyspnea and dry cough and impaired physiology of 1 year duration. She has a history of reading birds. On exam, she has splenomegaly. She reported moderate eye and mouth dryness. Her lab showed extremely elevated ESR, positive antinuclear antibody in a rather higher titer, as well as positive anti-lung. What is the most likely diagnosis? Is it DIP, discontinuous interstitial pneumonia? Is it HP, being Bird Fanisser? Is it LAP? Is it PLCH, as we are? This is cystic pathology, what we see in the HRCT, or it is fibrocystic sarcoidosis. She's a female patient with some autoimmune features, especially dryness of mouth and eyes, and positive serology in gut titer. If we see to the HRCT, we will see a cystic pattern. لما نشوف cystic pattern في ال HRCT لازم نشوف بس الcysts دي countable cysts ولا diffuse cystic pathology. They are countable cysts. This will take us to the land of either fibrocystic HP or lymphocytic interstitial pneumonia. The presence of this ugly parenchyma raises both possibilities. But if we go back to the history of the patient having dry eyes, having splenomegaly, having serology, positive serology in a rather high titer, this supports the diagnosis of being lymphocytic interstitial pneumonia related to Sjögren syndrome. So, if the diagnostic approach of ILD ده my talk اللي هتكلم عنه وهتكلم عنه بسرعة بقدر الإمكان. ILD ده final common pathway of broad heterogeneous group of parenchymal lung disorder, not one disease, not single disease, رغم التشابه الكبير في السيمتوماتولوجي. ILD is also termed as, this is the correct term, diffuse parenchymal lung disease. Not interstitial lung disease, it is diffuse parenchymal lung disease, which is further classified into idiopathic interstitial pneumonia and non-idiopathic interstitial pneumonia. The clinical features are non-specific, dyspnea, cough, and so on, with some extrapulmonary manifestations or not. So, when I am dealing with a case of diffuse parenchymal lung disease or ILD, I have to look to these 7 points. First, good history taking. Thorough history taking is very important in making up the diagnosis of interstitial lung disease, including family history, occupational and environmental history. The physical exam, which is of little value in making up a definite diagnosis apart from the bipedal crackles with clubbed fingers and the UIP, IPF, and the presence of squatting over the anterior aspect of the chest in cases of HP. Otherwise, the physical exam wouldn't add too much to the diagnosis, except the presence of any extra thoracic manifestations like joint or skin affection. The HRCT or the radiology is the gold standard definite for the making up the diagnosis in most cases of IPF, of diffuse parenchymal lung disease, or ILD. Some blood test will be of help, and Lastly, the bronchoscopic samples. The pen may have a good role in making up the diagnosis in certain types of ILD. But transbronchial lung biopsy is of limited value apart from the granulomatous lung disease. Surgical lung biopsy is really indicated nowadays. And the last point, you have to assess the severity of the disease and the dynamic of the disease. This is the role of the physiology, which is very important part in making the diagnosis and follow-up of cases of interstitial lung disease. This is a common diagram of diffuse parenchymal lung disease, either diffuse parenchymal lung disease of known causes or granulomatous pathology or other forms like LCH and LAM, or the bigger group, which is idiopathic interstitial pneumonia. This is the current classification of ETS-CRS of idiopathic interstitial pneumonia. We're going to go through it. But I have to deliver this message. If we are talking about IPF should be UIP. Should be UIP at radio, should be at UIP at pathology if we get a surgical lung biopsy. But not all cases of UIP are idiopathic pulmonary fibrosis. IPF stands for idiopathic pulmonary fibrosis and not for idiopathic interstitial pneumonia. It stands for idiopathic pulmonary fibrosis and not for interstitial pulmonary fibrosis. This is the prognostic classifications of ILD. As we move from the left to the right, we are moving from a rather good disease to a bad disease. We are moving from inflammatory pathology, and we have a good anti-inflammatory drugs, to pure fibrotic pathology. So this is a prognostic classification. Organizing pneumonia, either idiopathic or not, it carries a good prognosis. Drug reactions, connective tissue disease related, and most of them, cellular illness, IP, infection, all of these are inflammatory diseases. And so the prognosis is much better than fibrotic illness, IP, HP, UIP. To me, HP is the worst ILD. Actually, the fibrotic form of hypersensitivity pneumonitis. It is more worse than UIP, IPF. This is the three compartments to pick up the diagnosis of a case of ILD. First, history, as I have said. Second, physical exam, lab, and pulmonary function tests. Then the role of the radiology, which is the most important part in diagnosis, and really the surgical or the bronchoscopic biopsy. في الهيستوري هنركز على حاجات معنا age. في بعض الأمراض بتبقى more common in age, like what age are common in certain يعني some ILDs are common in certain age group, like sarcoidosis, the age between 20 and 40 years, sarcoidosis, connective tissue disease related, especially in SIP, scleroderma patient, LAM, PLCH, all predominate in this age group. IPF is the disease of old age, more than 60 years old. لو لقينا عيان أقل من 60 سنة في بداية الخمسينات أو أقل الأربعينات عنده UIP IPF، لازم نتأكد أنه عنده family history of IPF or not. Second, the gender. We have some ILD which are exclusively developed in females. طبعا اللي على رأسهم هو الليمفانجيولايوماتوزيس LAM. Sarcoidosis more common in females, chronic eosinophilia pneumonia more common in females, systemic lupus more common in females. Male predominance in PLCH and IPF, especially IPF. The incidence of IPF in males much higher than the incidence of IPF in females. جزء مهم جدا the history of smoking. Smoking, we have a spectrum of smoking related ILDs like RP-ILD, like DIP, discriminative interstitial pneumonia. IPF is more common in smokers, either former or current smokers. So all of these are smoking related ILD. The same for LCH. Smoking seems to be protective, partially protective against sarcoidosis and hypersensitivity pneumonitis. بس ده حاجة relative، مش حاجة absolute. الانسيدنس اوف ساركيدوز اند هايبرستيتينايتس اقل في السموكينج نتيجه لتاثير السموكينج على الانتي بودي برودكشن. We have a big list of drugs used in ILD. Any drug can cause interstitial lung disease, but the most common and the most famous tools are amiodarone and methotrexate. The drug-induced ILD could be acute, could be subacute, could be chronic. Genetic and family history is very important. Example of ILD in genetic ILD, Hermansky Budalik syndrome, Gaucher, all of them are rare ILDs. But we have to keep in mind that IPF is familial in about 3%. 3% of cases of IPF are familial cases. Risk of exposure is very important on all ILD, and you have to exclude the presence of exclude occupational exposure in the workup during the workup of a case of ILD, especially IPF. The symptoms are totally non-specific, as I have said. The common symptoms are shortness of breath, dyspnea, shortness of breath, dry cough. Sometimes you have some extra pulmonary symptoms which may be related to the ILD itself. مش من الضرورة إنها to point towards a systemic disease. Like HP has a lot of extra thoracic manifestations. The same for sarcoid. And we have entity called rheumatic sarcoid, وفي العيانين دول بيبريزنت على انهم روماتويد ارثرايتس، بيشخصوا لفتره طويله على انهم روماتويد ارثرايتس ويكتشفوا في النهايه انهم عندهم اتش بي. Regarding the extrapulmonary symptoms, much common dyspepsia, dysphagia, reflux in IPF, arthritis, connective tissue disease, muscle and skin symptoms, skin lesions, albinism, neurological manifestations, especially in sarcoidosis, biliuria, and polydipsia, also in sarcoidosis, hematuria, and pulmonary renal syndromes. The pulmonary signs, as I have said, قيمتهم مش عالية جدا, apart from the presence of crackles, biphasal crackles in some cases of IPF, UIP, IPF, or squawk sign in cases of HP, and you can pick up the signs of pulmonary hypertension. Also, pulmonary signs include clubbing. Clubbing has no diagnostic value, but it has a prognostic value. يعني عندي عين يو اي بي اي بي اف وعنده كلابينج، البروجنوز بتاعه بقى اوحش من عين يو اي بي اي بي اف without clubbing. Now I will speak about the lab testing. Also, lab testing rarely diagnostic, but may be supportive for appropriate clinical setting. Serology like ANA, rheumatoid factor, ACE level in sarcoidosis, which is totally non-specific, serum persistence in HP, which is also a silly test, and it's of little value, ANCA-P and C, antiglomerular basement membrane antibodies, methyl enzymes like aldolase, antigen-1 antibody, and so on. Immunoglobulins, very important. If you have hypergammaglobulinemia, this goes with sarcoidosis. If you have hypogammaglobulinemia with diffuse lung pathology, this can make up the diagnosis of أو يساعدنا في تشخيص مرض زي الجلد اللي هو granulomatous lymphocytic interstitial lung disease. HIV is important. Lab can happen in HIV, also the prostatic infections, peripheral blood lymphocyte perforations, and periglosis. Regarding the antibodies in connective tissue. Sorry. آسف بس معلش كنت خرجت. Regarding the autoantibodies in connective tissue disease, some autoantibodies have a prognostic value. The presence of U1R NP in scleroderma patients, this means that the NSIP of this patient will be progressive, will be fibrotic, will be resistant to treatment. For example, the role of pulmonary function is very important. First, to detect the degree, the severity of the disease. Second, which is most important, to monitor the response to therapy. I leave this part to الدكتور ياسر مصطفى. أنا عارف إنه هيتكلم عنها. مهم جدا السكس ووك تيست. أحيانا بيجي لك العام ب HRCT نورمال وعنده exertion shortness of breath not explained. لو خليته عمل مجهود طلع سلم مثلا وحصل له desaturation، ده يخليك تمشي جدا مع وجود ILD. للأسف ال HRCT مش X-ray. HRCT a normal HRCT doesn't entirely rule out the presence of ILD. Now هنتكلم على aurora of radiology برضه بسرعة، لأن عارف إن في محاضرة عن الراديولوجي. Normal X-ray doesn't rule out definite the presence of ILD. The same is for HRCT. The HRCT is the most important part in the diagnosis of ILD, and most ILDs can be diagnosed based on the CT on the HRCT. The HRCT should be good quality, high resolution CT. But don't interpret the HRCT in a vacuum. Don't interpret the CT in separations from the clinical history of the patient. لو نبص السلايد الأولى اللي فيها مجموعة من الصور، مجموعة من الاستتيهات. لو بصيت للصورة اللي فوق الأولانية دي diffuse nodular pattern. diffuse nodular pattern والعين سانت بلاستر مش بيتعرض لرمل ويقطع إزاز and so on. This is accelerated form of silicosis. يعني بزود the history how less than HP. the mediastinal cut اللي موجود تحتها في calcified mediastinal lymphadenopathy of the same patients. السلايد اللي في النص اللي فيها bilateral effusions وفيها nodules. The pattern of nodules هي random nodules. definite metastatic case. in contrast للنودولار باترن اللي موجود على اليمين فوق اللي هو الساركيدوزس اللي هو lymphatic nodules patching distributions اللي هي بتفولو الليمفاتكس ماشيه مع الاكزال interstitium مع البرونكوفاسكولار structures مع الفيشرز. the big fissures is beaded as we see. The second slide اللي فيها اشعات مقطعيه دي different forms of mosaic lung. The first one اللي هي على الليفت البيرد فانيسر وفيها بعض النيتيوز diffuse pathology affecting اللنج من فوق لتحت واليسان chest wall. فيها بعض السيستات، فيها air trapping، فيها مسيسازم بسيط HP. الاثنين اللي جنب بعض بعد كده الثاني والثالث من الشمال يعني اليمين. أول واحدة يمين اللي هي فيها definite مسيسازم black areas beside gray areas. لو هنبص هنلاقي ان في pulmonary veins are predominant in the black and in the gray areas. And this patient has exertion shortness of breath and gives a history of pulmonary embolism dating 1 year back. So it's the case of sharp demarcated mosaic parenchyma due to a basal disease which is chronic thromboembolic pulmonary hypertension. In contrast اللي بعدها black areas or gray areas.
دكتور يسري سامعني؟ دكتور يسري
هتسمعني بيه؟
في الراجل اللي هو بص يا يسري في الدكتور
انا ماشي بيمشي بسرعه خالص
لا خلاص. عشان احنا وير فيري ستيك في
ما انا قدامي 3 دقايق بالظبط.
ان هو خد بالك الدكتور منتظر دوره دلوقتي له في فيينا.
ماشي خلاص.
وهيتكلم عن الراديولوجي دكتور يسري.
تمام.
يا ريت معلش تدينا كونكلودنج ريماركس بالاكسبيرينس بتاعتك 2 or 3 سلايدز كده ات موست. اوكي
يا بس يعني ايه الحته الجزء الثاني ده
معلش يا يوسف مضطرين عشان السكادجول بتاعنا بس.
ماشي اوكي خلاص حاضر. الحاجه اللي بعد كده اللي هي السبتال سكننج. different example for septal seconding heart failure. The second one is veno-occlusive disease. The third one is lymphangitis carcinomatosis. Now I will move to the last part of my presentation. يعني عشان أجمع أهم حاجة في تشخيص ال ILD هي الهيستوري الإكزام والموست امبورتنت بارت في الحقيقة هو ال HRCT. نادرا ان احنا نحتاج بعد كده ان احنا نعمل سامبلز. لو خدنا البرونكوسكوبيك سامبلز اكثر حاجه مفيده في الفايبرو اوبتيك برونكوسكوبيك سامبلز في الاي ال ديز هي البال. والبال ممكن يعمل لنا يشخص حالات كتيره حتى بالجروس ابييرنس بتاعه، يعني زي ميلكي بال في حالات الالفولار بروستينوزيس، الانفكشنز، السيلولاريتي اوف ذا بال المختلفه في تشخيص الاتش بي، في تشخيص الساركويد، في تشخيص لانجرهانس سايتوزس، في تشخيص الالفولار هيمورج سندرومز. ترانسرانكر لانج بايوبسي يعني اوف ليميتد فاليو جدا في الايديوباتيك انترستيشن نمونيا. ما تفكرش ان عيان عنده ايديوباتيك انترستيشن نمونيا تعمل له ترانس برونكر لانج بايوبسي بالفايبر اوبتيك برونكوسكوبي، لكن هي مهمه في تشخيص الانفكشن والجرانيوماتس لانج ديسيز في الحقيقه. اخر بوينت، هل هتحتاج سيرجيكال لانج بايوبسي اور نوت؟ كلمه ان السيرجيكال لانج بايوبسي ريمين ذا جولد ستاندرد لا، هي اتغيرت تماما. هي العيان على بعضه عباره عن ايه؟ what is the history, what is the HRCT finding and what is the pathological finding. لازم يبقى في يعني تناغم ما بين الثلاث اذرع عشان نقول what is the diagnosis of what is the final diagnosis. surgical lung biopsy please هي نادرا ان احنا نستخدمها حاليا نتيجه للsignificant morbidity والsignificant mortality اللي ممكن تحصل معاها، بالذات في العيانين عندهم extensive honeycombing، الفانكشنال ستيتس بتاعتهم وحشه، عيانين هايبوكسيك and so on. يعني انا رايي ان الدور بتاع السيرجيكال لانج بايوبسي هي في المجموعه اللي بنسميها unclassifiable ILD. شكرا جزيلا واسف لو كنت طولت يعني.
شكرا دكتور يسري، ومعلش
انا خلصت بيه خلاص كده تمام.
ربنا شكرا وفيري كومبريهنسيف واب تو ذا بوينت. شكرا يسري، يا ريت تبقى معانا برضه يسري عشان لو هيبقى في
انا مع حضرتك يا بيه مع حضرتك، بس هو الصوت واطي من عندك
عشان
شويه
الراديو دي حاجه بقى في الاوديو بقى عندنا هنا تبع
مع حضرتك يا بيه الصوت واطي.
انا صوتي عالي لكن هو الظاهر الترانسميشن مش
تمام يا بيه.
انت نورتنا يا يوسف، كنا عايزينك بس فيس تو فيس وكلنا متطعمين. خد بالك معانا معالي الوزير دكتور محمد عوض، يعني اجباري كل الناس تخش متطعمه يعني.
استاذنا الكبير منور الدنيا طبعا.
الله يخليك يا حبيبي. ننتقل للاخ العزيز استاذ الدكتور ياسر مصطفى، استاذ ورئيس قسم الصدر في جامعه عين شمس، وهيدينا التوك بتاعته على الفسيولوجيكال تشينجز ان IPF.
ثانك يو مستر تشيرمان. الحقيقه بشكر بورينجر على اتاحه الفرصه لي ابقى موجود مع حضراتكم ومع اساتذتي الافاضل الاستاذ الدكتور محمد عوض والاستاذ الدكتور طارق صفا، عشان برضو يعني احتراما للوقت الحقيقه هنحاول ان شاء الله نتكل this very important subject which is the physiological changes and very hard subjects. الحقيقه يعني دايما البالمونري فيسيولوجي بيبقى من اصعب الحاجات، لكن الحقيقه البالمونري فيسيولوجي بالذات في IPF is very important in assessing the disease. يعني هو في الاخر العيان بيجي يشتكي من كومبلين، هذا الكومبلين ريفلكت الفسيولوجيكال تشينجز اللي بتحصل في اللانجز بتاعته ايفن حتى لو ما عندوش راديولوجيكال امبيرمنت واضح. الاجنده بتاعتي هيبقى فيها رابط introduction tackling the pulmonary interstitium which is the target site, pathological changes and how it can affect the physiology and the change in pulmonary function with IPF and its value in clinical assessment and follow-up. طبعا زي ما الدكتور يسري قال احنا عارفين مكان الاي بي اف هو طبعا مش كومن يعني قوي زي بقيه الانترستيشال لانج ديزيزز، لكن ما زال موجود وما زال بنشوفه. والحقيقه الفسيولوجيكال تشينجز بقى بالذات هي مش هيبقى ليها علاقه قوي بالاي بي اف بس، هي ريليتد لكل الانترستيشال لانج ديزيزز اللي بتحصل. طبعا التارجت سايت هو الانترستيشيوم، وكلنا نعلم الانترستيشيوم ده جزء من اللنج مع البالمونري سيركوليشن. الانترستيشال كومبارتمنت is the portion of the lung sandwiched between the epithelial and endothelial basement membrane، وزي ما حضراتكم شايفين بتشارك فيه الالفيولار سيل وبتشارك فيه الاندوثيليال سيل وبتشارك في تايب 1 وتايب 2، وبيشارك في بعض الانترستيشال فايبروبلاست لان دي هيبقى عليها كلام بعد شويه، وطبعا موجود الماكروفيجز وبعض الانفلاماتوري سيل. ده شكل الانترستيشن البديع اللي طبيعي جدا. ايه اللي بيحصل الحقيقه في الاير واي ابيثيليوم؟ ده المكان اللي بيحصل فيه الدمج او بيحصل فيه الهامرنج. الكرونيك and repetitive micro injuries of the alveolar epithelium as triggers of the disease. This may include environmental pollutants, cigarette smoke, acid aspiration, and viral infection. والحقيقه بينتج عن هذا التشينجز اللي بتنتهي بعد كده بتكوين فايبروبلاستيك سبوت زي ما حضراتكم شايفين كده في الصوره دي تحت هنا. بيبقى الابيثيليال damage followed by injury and reactivation of cells lining the vascular and interstitial, mainly the mesenchymal cell including the alveolar fibroblast compartment of the lung. بيبتدي يحصل الفايبروزيس والتشينجز اللي حضراتكم بتشوفوها. فبيبقوا الحقيقه كذا حاجه بتحصل زي هنا A alveolar wall thickening and fibrosis in IPF, B walls of collagen replacing alveoli in IPF, we see show collection of alveolar macrophages filling alveolar space in the squamative interstitial pneumonia. كل الحاجات هنا بتحصل او التشينجز بتحصل في الالفيولاي، وبالتالي هتبقى الافكت اون ذا فانكشن اند فيسيولوجي هيبقى ميلي على مستوى الالفيولاي وما يحيط بالالفيولاي اهمها البلاد فيسلز. اليونت اوف ذيس از ذا myofibroblast large cells لان دي contractile cells بتبتدي تتجمع في الانترستيشيوم وبتدي تسكريت الكولاجين ويبتدي يحصل المشكله اللي احنا بنشوفها. طبعا ده بيبقى احيانا او commonly معمول علشان to protect the lung and to heal the lung مش بس all other tissues. لكن مشكلتنا هنا ان النورمال apoptosis of these fibroblasts اللي بتطلع في اي injury لللنج نورمالي كلنا بنتعرض للنج انجري يوميا يحصل لها المفروض ابوبتوزيس. الابوبتوزيس ده بيختل ويبدا يحصل الفايبروزيس والفايبروبلاست تفضل قاعده وتجيب الكولاجين and then fibrosis of the interstitial will happen. فيبقى اللنج الحقيقه بتتحول لفايبروتيك فوساي ومنها تبدا تحصل الفايبروزيس اللي بيحصل والتشينجز اللي هتحصل بعد كده. مينلي طبعا ده بيبقى في الانترستيشيوم مش في الاير ويز، لكن الحقيقه بنلاقي احيانا ان الاير واي بيحصل فيها بعض الباثولوجيكال changes which may be hidden by increased elastic recoil tending to hold the large airways. تلاقيها وسعت شويه، عشان كده احيانا زي ما هنشوف بعد شويه الاف اي في 1 تو اف في سي بيزيد شويه نتيجه ان بيحصل بعض الدايلاتيشن لللارج ايرويز. How these pathological changes affect the pulmonary function. This is our aim from my talk. احنا lungs بتبقى ابتدت يحصل فيها fibrosis so it will shrink like this and this definitely will affect the vital capacity and the total lung capacity and are the main issues. It looks like this sweatshirt when it shrunken and it needed to fit the same body. There will be a defect here in oxygenation because we have smaller size lung than the usual we need. This one of the mechanisms which lead to shortness of breath and dyspnea, and the other is the impairment of the gas exchange at the level of the alveolo-capillary membrane, leading to definitely the effect of hypoxemia and changes in the blood transfer or gas transfer, as we will see after a few minutes. Pulmonary functions will include lung mechanics, lung volume, and gas exchange. Lung mechanics definitely will be affected. The chest wall mechanic property في interstitial lung disease appear to be normal, and the reduction of functional residual capacity is due to the downward and rightward shift of the lung V curve. ده البي في curve اللي بيشوف الكومبلاينس العلاقه ما بين البريشر والفوليوم. Although patients can generate high inspiration pressure, the total lung capacity is reduced because of the replacement of alveolar units by fibrous units زي ما حضراتكم شايفين هنا في عيان اللي عنده interstitial lung disease اللنج كاباسيتي والتوتال لنج كاباسيتي بتقل جدا. The typical spirometrical finding in IPF are reduced vital capacity and normal or increased FEV1 over VC زي ما حضراتكم شايفين هنا في الكيرف. ده النورمال بيبقى ال FEV1 بتمثل فوق ال 75-80% من الفوليوم. هنا هتبقى اقل ان كل الكيرف قل، فبالتالي الريليشن ما بينهم مع الدايلاتيشن اللي بيحصل في اللارج اير ويز من الفايبروزيس ممكن يعلي ال FEV1 بالنسبه لل FVC. وطبعا الماكسيمم فلو at 50% of forced vital capacity في الفلو فوليوم كيرف can vary widely from higher to lower than normal, but when the flow are adjusted for lung volume the flows are normal or high in most cases. دي حاجه من الحاجات اللي بتقيس لنا بسهوله شويه، لان العيان ده بيبقى صعب انه يعمل المانوفر بتاع السبيرومتري وهو الامبلس اوسيلومتري. وزي ما حضراتكم شايفين في الصف اللي تحت لما يبقى في ريستريكتيف لانج ديزيز الاي او اس ريزيستنس بتفضل ثابته تقريبا زيها زي النورمال اللي فوق، لكن الرياكتنس هي اللي بتختلف، وده من الحاجات اللي بيساعدنا جدا لما العيان مش قادر يعمل التست. الديفيوزنج كاباسيتي طبعا اللي هي قدره اللنج على نقل الاكسجين بنقيسها عن طريق ترانسفير فاكتور بميجرمنت من خلال الترانسفير اوف كربون مونوكسيد and the measurement of transfer factor using carbon monoxide with the single breath technique is important to diagnose and is commonly reduced in all interstitial lung disease and can be abnormal when lung volumes are still within normal. ودي الحاجة المهمة الحقيقة، هو more sensitive في الدياجنوزز early عن lung volumes. يعني ممكن نلاقي lung volumes تبقى نورمال وده بيبقى افكتد. الحاجه الثانيه المهمه جدا وهو الارتيريال بلاد جاز اناليسيز اللي هو الاناليسيز اوف oxygen and carbon dioxide, and you know that in IPF usually the oxygen is affected. بيبقى فيه طبعا hypoxemia في صوره decrease in PaO2 and oxygen saturation، وما بيبقاش فيه hypercapnia. يمكن ده علشان الhypercapnia is affected mainly by ventilation and not by diffusion, and here the patient due to hypoxia and the stretching of the interstitium there is a tachypnea. There is increase in the heart rate, and this increased heart rate will increase the ventilation and so will wash the CO2, and we find those patients have even normal or low CO2. فبيبقى المين ايشو هنا الهايبوكسيا. What about exercise capacity is very important, and CPX test may be abnormal in early disease preceding the abnormality في other lung function test with the emerging importance of high resolution CT. The test is often not performed as part of the diagnostic workup of IPF. وبنستبدله بتست very practical اللي هو 6-minute walk test. الحقيقة simple and can predict morbidity والمورتاليتي في عيانين interstitial lung disease. بيحدد لي distance walked during the 6-minute walk, particularly if less than 200 meters. It means in في respectable affection, degree of desaturation during walking, and the heart rate recovery after the 6-minute walk test is a good predictor for mortality. وفي papers اتنشرت على الموضوع ده. الاسسمنت اوف pulmonary hypertension is very important عشان احنا اتفقنا ان الجزء اللي بيبقى affected او التارجت اوف افكشن اللي هو الانترستيشن في blood vessels. احنا مش بس بنأفكت الالفيولاي. So pulmonary hypertension is commonly associated with IPF, present for around 32% of cases, particularly in advanced disease. يعني تقريبا ثلث الحالات. Its presence predict increased mortality expected when the total lung أو transfer capacity بتاعة اللنج اللي هي ال CO is very low and there is severe desaturation on exercise. Echocardiography and pulmonary artery diameter are unreliable in estimating pulmonary hypertension. ولو عندي manifestations of pulmonary hypertension واضحة مع normal echo, I should go to right side heart cath إذا كان ده هيفرق في حاجة مع المانجمنت بتاع العيان، زي ما هنشوف مثلا لو هيتعمل له lung transplant ولا حاجة، خاصة البروجكت ده هيبدأ عندنا إن شاء الله قريبا. Can we classify السيفيريتي بتاعت الاي بي اف من البلمونري فانكشن؟ الحقيقه مش زي السي او بي دي مثلا او مش زي الاوبستراكتيف ايروي ديزيز. Terms such as mild, moderate, and severe are sometimes used for staging diseases. and are commonly based on resting pulmonary function test measurements. And however, there is no clear consensus regarding the staging of IPF patients and what are the best criteria and values to use. لكن الحقيقة mild to moderate IPF has been characterized by the following functional criteria. لما تبقى ال FVC بتاعتهم أكثر من 50، الدلكو ما قلش عن 30، وال6 minute walk distance ما قلتش عن 150 متر، ده بعتبره mild to moderate. لو نزل تحت الأرقام دي بنعتبره severe. النقطة الثانية اللي مهمة الحقيقة وهي البروجنوستيك values أو البروجنوستيك أو الأسسمنت of deterioration, because this may govern the choice of the therapeutic modality. زي ما هنشوف في التيك هوم messages بتاعتي. Physiological changes are behind all symptoms of patients of IPF and should be carefully assessed and followed. Physiological deterioration are important predictor of mortality and morbidity and mortality. Functional assessment and follow-up can driven management plan like rehabilitation program. ما اقدرش اعمل rehabilitation program قبل ما اكون عامل full functional assessment، بالذات يكون في 6 minute walk test. والحاجة الثانية ال good timing for choosing this patient for lung transplantation. As you know that we have a long list which is more benefit from lung transplantation from another one. This will be predicted by the deterioration. When the patient deteriorated rapidly, transfer factor or total lung capacity more than other people, he will be more liable or priority for lung transplantation. Thank you for your assessment, and any question I will be ready.
Thank you very much, Professor Yasser Mustafa, for your excellent presentation. It's not only physiological changes, but it was also histopathological changes. Thank you very much. We'll keep the discussion at the end of the session. Now, الخواجة موجود يا جماعة الهوا ولا ايه؟ طيب فين هو؟ عايزين نشوفه يعني. Okay, now it's my pleasure to introduce Professor Helmut Brosch, Professor of Radiology and Section Chief of Thoracic Imaging at the Department of Biomedical Imaging and Image-Guided Therapy, Medical School of Vienna. Professor Helmut will give us a lecture about radiology of IPF. Good afternoon, Professor Helmut.
Good afternoon. I don't know what you are seeing right now on my screen. Just a second. I have to change my settings. It should work in a second. Do you hear me?
Yes. My name is Professor Taguddin. I am Professor of Pulmonology at Ain Shams University, Cairo, Egypt. And my colleague, Professor Tariq Safat, is my colleague, and he is also Professor of Pulmonology at Ain Shams University, Cairo.
I'm very pleased to meet you. I just realized I have to restart Zoom because the computer requires that. So just give me a second. I will be quickly on a. Oh, now it should work. And I should be able to share my screen. Share. So now you should see my screen. Is that right? Is that correct? Do you hear me? Apparently not. Do you hear me? Hello.
We can hear you, Professor Brosch. We can hear you.
Okay.
You can start. You can start.
Okay. Thank you so much. So thank you for your patience. Yeah. I was asked to give you a talk on the management or the diagnostic approach from a radiological point of view on IPF. Here are my disclosures. None of them are pertinent to this talk, besides the cooperation I have with BI and some cooperation also with Roche. Okay, so you heard already a lot of the context of IPF, and IPF belongs to the interstitial lung diseases, and there are so many. And when it comes to differential diagnosis, one thing which is always important is to know about the probability that you might be dealing with such a disease. And looking at the interstitial lung diseases in general, we know that IPF is a very common disease. In fact, it's roughly 20% of all interstitial lung diseases, so it's a really important disease. It is more common than all brain tumors taken together. So it is an important disease. Then there are other diseases which have an impact also on our differential diagnosis, like connective disease, tissue disease related ILDs, because the clinical and CT manifestations overlap in substantially here. Then hypersensitivity pneumonia, which is very common in Austria, and I don't know about Egypt, but here it is a very important differential diagnosis because it's quite common. And then sarcoidosis and other diseases. So the task of radiologists is to identify patients with IPF, and we try to avoid to perform a biopsy, and I will get to this in a second. And I heard this, you heard this already, so I can be brief here. The etiology is unknown.
Professor Brush, excuse me.
Yeah.
The audio system asked me to tell you to be near from the microphone as much as you can.
Okay.
This is the recommendation from them.
Yeah, sure. Probably I changed the microphone. Just give me a second. Is it better now? Do you hear me better now?
Yes, go ahead, please.
Okay, so I will continue with that microphone. And the important point here is, from a radiological point of view, that's always very important for us radiologists, the differential diagnosis, and age is an important point here for the differential diagnosis. This is a disease of the elderly. And UIP is the CT pattern, the pathological pattern we see in UIP. And for many years, the diagnosis of IPF was primarily based on histology. And what you see in histology, what we know it already, the prognosis is so bad, we heard it already, but what you see in histology is quite well defined. It's a combination of a very severe lung fibrosis with the so-called microscopic honeycombing and the presence of fibroblastic foci. So this is a disease which is primarily defined via pathology. The problem is that biopsies can frequently not be taken, and they are problematic in and by themselves, because frequently the biopsies are not diagnostic because there is some sampling error. The pathologic changes may be non-specific, and even more so, the biopsies may be risky because patients are frequently compromised in their respiratory function, their comorbidities, and there is this risk of exacerbation. And for these reasons, we try to avoid a biopsy by predicting the histology by using CT. And if you look at the CT manifestations of IPF, there is quite a variety of CT manifestations you may see. But if you look closely at the probability that a certain pattern reflects UIP, you can identify patients according to this probability. And there's a patient group which has a very high probability that the histology would reveal UIP. This is what we call the typical UIP pattern. And then there are other patients in whom the diagnosis of UIP/IPF is very unlikely. And then there are patients with CT findings which may overlap with other diseases, but still the probability that this is UIP is quite high. We call it the probable UIP pattern. And then there's this fourth group, which we call indeterminate for UIP. In this group, the probability for UIP is almost 50-50. So these are more likely patients who should undergo biopsy. And in the context of probable UIP, we try to add clinical factors in order to increase the probability that we are really dealing with UIP/IPF. So how do we do that? And we do that by a systematic approach of our CT findings. And we do this in a 3-step approach. We first look at the CT pattern. Then we'll get to that in a second. Then we look for ancillary findings, and last but not least, the differential diagnosis of fibrosing lung diseases in general, but in IPF in particular, is based on the distribution of these findings. And this leads us then to a disease pattern, which in combination with the clinical context will lead us to the diagnosis. So when it comes to CT patterns in fibrosing lung diseases, there are primarily 2 patterns we observe. So the most common ones are ground glass and reticular abnormalities. And ground glass is unfortunately a very non-specific finding. You may see ground glass in the context of lung fibrosis. Yes, you may see it primarily in patients in which an inflammatory process is leading to lung fibrosis, as we see in connective tissue diseases in the form of non-specific interstitial pneumonia or in hypersensitivity pneumonia. But ground glass is also seen in inflammatory diseases, in infectious diseases. So in and of itself, it's not a good pattern to predict the presence of fibrosis. Reticular abnormalities, on the other hand side, are more commonly seen in fibrosing lung diseases. You may also see patients with reticular abnormalities in which this is completely reversible. But still, if you see reticular abnormalities, these irregular lines crisscrossing here, the probability that you are dealing with a fibrosing lung disease is very high. So these are the 2 primary patterns we see in fibrosing lung diseases, and whenever you see ground glass and or reticular abnormalities, you should consider a fibrosis, but you know that this is not a proof of fibrosis. So the next step would be to look at the probability of fibrosis, and this is just an example here. 2 patients with ground glass, and I mentioned already ground glass can be fibrosis, but it's not a proof of fibrosis. And if you look at these 2 cases, it's really difficult to tell which one of which here is a patient with a fibrosing lung disease. And to make a long story short, here, this patient on the left side, suffers from PCP, pneumocystis cerevisiae pneumonia, whereas this patient here on the right side has a fibrosing NSIP, but just by looking at the CT pattern, by the density, you can't really tell them apart. And it's also similar here for reticular abnormalities. This is a patient who presented with acute symptoms of dyspnea, and you see here these reticular abnormalities. And just by looking at these findings, you might get into the idea that this is a fibrosing lung disease. However, this was bleomycin-induced lung toxicity and was completely reversible. So patterns alone do not suffice to diagnose a fibrosing lung disease, and we do have to look for additional findings which point towards lung fibrosis. And what we do is we look at the effect of fibrosis. What fibrosis does is it leads to a loss of volume. And this loss of volume can be appreciated on chest radiographs, as shown here with the elevation of the diaphragms, but can also lead to an elevation, to an enlargement of bronchi. We call this traction bronchiectasis, which is characterized by this irregular or also varicose-like enlargement of bronchi. And importantly, the lung parenchyma surrounding these bronchi has to be altered. You have to see either ground glass and or reticular abnormalities, because if the surrounding lung parenchyma would be normal, you would be dealing with a bronchial disease and not a fibrosing lung disease. And last but not least, the real proof of fibrosis on a CT scan is honeycombing. And honeycombing is defined by these multi-layered cystic spaces, as you can see here. And this honeycombing is the real proof of fibrosis. So you see these clusters of cysts. They are thick-walled. They have a really well-defined wall, and neighboring cysts are sharing their walls. This is important here to mention because sometimes you see cystic lung diseases with a number of cysts. But here you might also probably run into the idea that this is honeycombing, but as long as these cysts are not sharing their wall, it's not honeycombing by definition. And importantly, UIP is a common finding in UIP, but I have to stress out here, it's just seen in this very typical form of UIP. If you do not see honeycombing, this does not exclude UIP. So this is just one characterization, one specific manifestation of lung fibrosis. And we see this most commonly in UIP, but also quite commonly in fibrotic hypersensitivity pneumonia or in unclassifiable lung fibrosis. Moving on here now to this. These are now two patients, both of which have ground glass, and ground glass should us also always remind that this might be lung fibrosis. You see traction bronchiectasis in both cases, so you know that this is lung fibrosis, but these are two completely different diseases. And how do we distinguish these two diseases? Yes, by definition, and you already assumed that. Here on the left side, this is non-specific interstitial pneumonia, in which you see this ground glass primarily in the basal and dorsal parts of the lung. Whereas this here on the right side, this is a patient with chronic hypersensitivity pneumonia, and you see that lung fibrosis is seen all over the lung parenchyma. So distribution is super important for the differential diagnosis. This is the key to lung fibrosis. And to make difficult things easier, I limit here my discussion to the four diseases you primarily see in lung fibrosis, which are the UIP pattern. And in UIP pattern, the distribution is basal and subpleural with a subpleural predominance. Then there's also another fibrosing lung disease, the non-specific interstitial pneumonia, in which you also see a basal and subpleural predominance. Sometimes you see a subpleural sparing, and in contrast to UIP, the distribution is usually homogeneous. And also, some of you may know that already, in UIP, you see primarily reticular abnormalities, and in NSIP, you may see both reticular abnormalities or ground glass. And then we have the biggest chameleon here in this room, which is fibrotic hypersensitivity pneumonia, which in its nicest form, its most characteristic form, shows a random distribution of findings, both axially and caudally. And then last but not least, fibrotic granulomatous diseases such as sarcoidosis or pneumoconiosis usually have an upper lobe predominance. But as you may have seen here already, there is quite a substantial overlap. And this is why we have to analyze pictures very systematically in order to be very specific with our diagnosis. But the distribution is the main key to the differential diagnosis. So let's look at some cases just to show you how important that is, what I just told you. This is a 75-year-old female patient with dyspnea exertion. And let me first click you through the pictures just to give you an impression of what you see here. That's also what I do whenever I perform a CT scan. I first just scroll through the pictures to get an impression of what I'm dealing with here. And what we see here in this patient are clearly reticular abnormalities, which should give us the idea that we are dealing with a fibrosing lung disease. So we look for signs of lung fibrosis, loss of volume, traction bronchiectasis, and honeycombing. And we see that here in this patient. We see here this clustered cystic spaces, which we would define as honeycombing. You see also here traction bronchiectasis. So this is a lung fibrosis. And as to come now to a diagnosis, we look at the distribution, and you can clearly see here that there is a basal and subpleural predominance of these findings. And this makes our differential diagnosis now a lot easier, because this is what we would call the typical UIP pattern. We see reticular abnormalities as the main CT pattern. We see, in addition to that, as sign of lung fibrosis, we see the honeycombing. And the distribution is very characteristic. We see this basal and subpleural predominance, which is often quite heterogeneous. And last but not least, there are no signs to suggest other diagnoses. And we will get to that in a second as well. Just first stick a little bit more to this honeycombing, because this is the central point in the diagnosis of UIP. And as easy as it may sound, the diagnosis of honeycombing is frequently quite difficult. Just give me an example how honeycombing should look like. This is a gross pathology of this patient here. And you see here the cystic spaces as seen on CT, and these correspond nicely to these air-filled cystic spaces in the spatial part of the lower lobe. But then there are also tricky cases like this one here. On the first glimpse, you might get the idea that you are dealing with a honeycombing. However, if you follow these cystic spaces, you will see that they are interconnected. And in essence, these are not cysts. These are just traction bronchiectasis in very, very close vicinity to each other. And this is sometimes not that easy to see. And if you're uncertain, it's helpful to look at so-called minimum intensity projections, which make you better and make it easy to understand that this is not honeycombing, but just traction bronchiectasis. Really important, because the diagnosis is different. In this case, the diagnosis is NSIP, non-specific interstitial pneumonia, and not UIP. Has treatment implications, has prognostic implications. One thing more to mention is that UIP is not a diagnosis of a disease, it's a diagnosis of a pattern, and you see this in a number of diseases, most commonly in IPF, the idiopathic pulmonary fibrosis, but you may see this in a number of diseases like rheumatoid arthritis, scleroderma, hypersensitivity pneumonia, familial pulmonary fibrosis, sarcoidosis, as well as asbestosis. And this is then the job of the pulmonologist to see, to identify any disease which may lead to that or exclude everything else, and so to come up with the diagnosis of IPF. And this diagnosis of IPF may change over time, because in some patients, UIP may precede the diagnosis of a connective tissue disease, and this was investigated in a nice study of 111 patients, and they could identify over a period of 10 years that 15% of these patients later were diagnosed with a number of diseases like microscopic polyangiitis, rheumatoid arthritis, or systemic sclerosis. So the diagnosis of IPF is frequently more a working diagnosis. You treat the patient, the diagnosis of the patient with IPF, you treat it accordingly, but the diagnosis may change. But the same holds true for NSIP. Also here, this idiopathic NSIP can change then to the diagnosis of a connective tissue disease, as we know also from our clinical routine. Moving on, also, I mentioned already this honeycombing, super important finding for the diagnosis of UIP. But honeycombing is not a unique finding in UIP. You see this also in fibrotic hypersensitivity pneumonia. In contrast to UIP, in fibrotic hypersensitivity pneumonia, the honeycombing is frequently seen in a non-basal predominance, so the differential diagnosis is then much easier. But sometimes you may also see a basal predominance, as we see in UIP. And in these cases, you have to look for signs which would indicate that you might be dealing with a hypersensitivity pneumonia, which is primarily signs of a small airway disease like air trapping or centilobular nodules. So this is what the criteria for the diagnosis of the UIP pattern mean with this fourth point. Even though you see all of the other 3 points fulfilled with the reticular abnormalities, honeycombing, and the basal predominance, you have to look for signs which would point towards another direction, and this could be a more peribronchial predominance of finding, which would be a very unusual in UIP. If you see lots of ground glass in the context of honeycombing and the basal predominance, you should consider other diagnosis. And then if you see consolidations like here, this makes a diagnosis of UIP very unlikely. Look specifically for signs of centilobular nodules, as they indicate that you might be dealing with a UIP. If you see these paralymphatic nodules, you would consider primarily sarcoidosis. Just to give you some more ideas, the air trapping outside of areas of fibrosis is usually not seen in patients with UIP, but you may see areas of air trapping within the lung areas of fibrosis in patients with UIP in the context of IPF. So just to give you the differential diagnosis, the most important differential diagnosis for all fibrosing lung diseases, which is typical fibrotic hypersensitivity pneumonia. And here you see a combination of a small airway disease characterized by central lobular nodules and or air trapping, and patterns indicative of a parenchymal disease, meaning ground glass, mosaic attenuation, or the 3 density pattern. And this is combined with local lung distortion, traction bronchiectasis, and or honeycombing. And again, distribution, this is the most important point, is something you see also in hypersensitivity pneumonia as a very important feature. And here the distribution is usually quite random, both axially as well as craniocaudally. Okay, so now as far as we just touched on fibrosis with honeycombing, but what if you do not see honeycombing? Like in this patient here, we see here primarily reticular abnormalities. Here, as you can see here, reticular abnormalities in a basal predominance. We see as a sign of fibrosis, traction bronchiectasis. So this is a fibrosis, but we don't see honeycombing. So what are the differential diagnoses in such a situation? And here the differential diagnoses are quite broad. This could be UIP, but this could also be this reticular form of non-specific interstitial pneumonia, which is quite common. And then it could also be this nasty disease, fibrotic hypersensitivity pneumonia, which has so many differentials. So what do we do? The worst situation here would be UIP. So we call it probably UIP as long as we don't get a better diagnosis. And probably UIP is characterized by a CT pattern with reticular abnormalities, and it has to be combined with traction bronchiectasis, peripheral traction bronchiectasis, because otherwise you would not know if you are dealing with a fibrosing lung disease. And the distribution is basal and subpleural. And again, now you have to exclude hypersensitivity pneumonia as good as it gets. There shouldn't be central lobular ground glass nodules or extensive air trapping. Now, how do we differentiate idiopathic NSIP from IPF in this context? So if there is no honeycombing, and we do that by looking at the age. Patients with IPF usually present at an older age with a median age at around 67, whereas in idiopathic NSIP, these are much younger patients. So if you are dealing with a patient who is older than 60 or 65 with a UIP, probably UIP pattern, the probability that this is IPF is very, very high, and thus we usually do not biopsy. Whereas in young patients, meaning 55, 50 or so, you do not know. This could be IPF, this could be IPF or another form of UIP, and could also be NSIP. So these are the patients where you would consider biopsy, but these are also the patients in whom the probability of complications is rather low. And this is also what the Fleischner Society indicates in their guideline. If a patient presents with a probable UIP pattern, and he is older than 60, a current or former smoker, and has no history of other potential causes of fibrosis, you would diagnose IPF without a biopsy. This is important here. While in the other situation, in younger patients or in non-smokers, you should consider a biopsy, because here the positive predictive value of this defined probable UIP pattern is not high enough. So what about these ATS guidelines? The ATS guidelines are somewhat different. They say that they suggest surgical lung biopsy in such a situation, but if you look closely, suggest means that the biopsy is appropriate in the majority of patients, meaning 50%, but maybe not appropriate for a sizable minority, meaning 49% or less. And if you look then also look through the follow-up papers, they have pretty much the same concept as the Fleischner guidelines. If the clinical context fits with IPF, you should really consider not to perform a biopsy, because biopsies are risky. So sometimes I get the question, when should we just wait to see if probable UIP develops into a real UIP and treat then? The answer is because this is not something you need to necessarily see. This is a patient with reticular abnormalities, which later developed into honeycombing, but this is only seen in about half of the patient. In 40% of the patient, you see just more traction bronchiectasis, but no honeycombing. And then in other patients, in a minority of patients, you don't see much of a change at all. So it does not make much sense to wait, because lost lung function can't be recovered, and patients should be diagnosed and then treated as soon as possible. What about a such situation like this one here? Here you see reticular abnormalities, but as you can see, there is no clear peripheral predominance. These fibrosing changes are primarily surrounding the airways. So I couldn't diagnose this as probably UIP, but it does also not fulfill criteria for other fibrosing lung diseases. And this is what is meant with this indeterminate for UIP. So here you see signs of fibrosis with a variable or diffuse distribution. But then there are also some inconspicuous features suggestive of a non-UIP pattern. And these are then the cases in which you should consider a biopsy. Other examples would be reticular abnormalities with a basal and subpleural predominance with no traction bronchiectasis, so that you don't even know that you're dealing with a UIP because you don't have signs of fibrosis. Last but not least, just a brief glimpse to NSIP, because that's an important differential diagnosis. This is a typical case with NSIP. You see here ground glass opacities here in a typical basal and subpleural predominance. In certain areas, you also appreciate a somewhat sparing of the subpleural space, and you see traction bronchiectasis as sign of fibrosis. And this is a typical case of NSIP. NSIP is characterized by the presence of ground glass opacities and or reticular abnormalities. And you see also a low volume loss, traction bronchiectasis, and the distribution is clearly basal, predominant, quite uniform, with sometimes a subpleural sparing. And you should not see signs which point towards other diagnoses, in particular central lobar nodules or air trapping, which would point towards hypersensitivity pneumonia. So how do we come to a diagnosis? The solution is very straightforward. We have to have a very thorough clinical evaluation, and then we discuss the CT findings in a multidisciplinary team to come up with a working diagnosis. The diagnosis may change over time, as I showed you with the connective tissue diseases, and sometimes we need a biopsy, but the decision whether or not to perform a biopsy should be made in the multidisciplinary team, and then also the results rediscussed. Thank you very much.
Thank you very much, Professor Helmet, for your wonderful presentation and the dilemma we're facing as physicians in the interpretation of interstitial lung diseases, the UIPs and NSIPs, etc. So please be with us, because we're going to have some panel discussion and some questions and answers. Thank you very much.
Thank you very much for your excellent expose. I have two comments. From your experiences, did you feel that interstitial lung diseases are idiopathic? Is it really idiopathic? We recorded about 120 drugs can introduce interstitial lung disease. The second point is during the era of COVID-19 pandemic and the recorded cases of lung changes, lung lesions, and mostly fibrotic, related to acute phase of the disease or the long-standing effects in some patients, which is called post-COVID syndrome or long COVID syndrome. So that, is it possible that one of the causes of these changes, either by viral or bacterial or both, or its autoimmune response, especially after the reversibility of many lesions with the systemic use of corticosteroids? I know that there is some lesion which is irreversible, chronic, long-standing, but most of the cases are responding to treatment. Thank you.
And these are indeed two excellent questions. One thing in regard to the diagnosis of IPF, IPF has to be considered as a working diagnosis. So if you follow patients closely over time, you may diagnose in a substantial subgroup of patients that you're dealing with a hypersensitivity pneumonia as a additional disease or as the underlying disease, and then you would consider also to focus on antigen avoidance. Or you may see then the development of a connective tissue disease. But still, these are progressive lung diseases. If the disease is progressive, you still should treat these patients accordingly. So the diagnosis, IPF is a diagnosis, but it's always difficult to tell if you're in the individual patient, if this is really the very idiopathic form or not. And we know for many other diseases which had this idiopathic title, and then we learned over time that there are subgroups which are well defined, but we are not there yet here in IPF. We know that the number of genetic factors which have a major role, but at the end of the day, we know that this is a progressive fibrosing lung disease, and this is what it makes so important to diagnose and treat. So to that point. COVID-19 is a different story, I think. COVID-19 is a disease which has a quite distinctive CT pathology. So if you look at the CT and also then the corresponding pathologies, the diagnosis there is organizing pneumonia. And organizing pneumonia is in most of the cases, or at least many cases, very well treatable. Sometimes it takes a very long time to get these findings away. But there are some patients, and we know this also from other diseases in which organizing pneumonia is present, like in this dermatomyositis, polymyositis, and other diseases. In some patients, you see the development of a fibrosis. And this is something we will see in the future. So fortunately, it's a minority of patients which have this very long-standing complications, but we will see this in the future for sure.
Another question from myself, and we leave the floor if they want to answer to pose any question for you. Let me ask a question from your practice. Professor Prosh, how much you think you have to refer the patient to the surgeons or to the endoscopist, the pulmonologist, to have a proper diagnosis? Do you really need to send someone for whatever biopsies, lavage, cryobiopsies, transbronchial lung biopsies, or you prefer to send the patient to the surgical biopsy? And the second, to continue my question, do you think it will help much in the roadmap against or the treatment in the future, planning for treatment?
The question whether or not to send the patient to a biopsy depends a lot on the clinical context. So if your patient has a typical UIP pattern and everything fits, patient will not undergo a bronchoscopy or biopsy. If the patient, particularly in younger patients, or in patients in whom we suspect that there is a hypersensitivity pneumonia in the background, a lavage is performed. And we perform only very rarely lung biopsies. And in almost all of the cases, we start with cryobiopsies. And if the cryobiopsies are not diagnostic, then we discuss whether or not to perform a surgical biopsy. Surgical biopsies are very rarely performed in our center meanwhile.
With no comorbidities happening or no complications which can happen. And you have in your practice the MD multidisciplinary discussions in your department. You have this as a rule, I mean, before going to surgery?
Yeah, we have a multidisciplinary board meeting, just pulmonology and radiology weekly. And every second week, twice a week. Then we have every second week a meeting radiology with rheumatology to discuss lung cases. And then every second week we have also a big MDT with radiologists, pulmonologists, rheumatologists, dermatologists, pathologists, and also colleagues from cardiology in regard to pulmonary hypertension. So that's quite a big MDT then, which takes place every second week.
Thank you, Professor Prosh. And I don't know if someone of the panel would like to ask a question. Professor Yusri, are you with us or you're out now?
I am with you, Prof. Tarek.
Would you like to ask any question?
No,
Professor Prosh?
No, just a comment. I will add a comment for the effect of COVID in the lung. I see cases with UIP pattern. I know that the COVID-19 is a pandemic of organizing pneumonia, but in some cases, the organizing pneumonia resolve and leave the lung with UIP, typical UIP pattern like that of UIP IPF. So in these patients, we add antifibrotic drugs. And we see some improvement, clinical and physiological improvement in this group of patients, despite of resistant radiological abnormalities. This is my comment.
Yeah, we had also 2 patients in our center which were initially diagnosed as post-COVID UIP, but then we went back and in both cases we found old images which showed that there were also signs of lung fibrosis prior to COVID. So one can discuss if this is a COVID infection UIP diagnosed in the context of COVID or not. But I agree there's also anecdotal cases published in the literature showing that you may see the development of a UIP pattern in COVID, but I think it's exceedingly rare.
Thank you, Professor Prosh, for your being with us. And we're now having a coffee break. We'll be very happy that you join us for an Egyptian cup of coffee, because we need a cup of coffee now. By the way, what's the time now in Austria, in Vienna?
I'm in Chicago. It's 8 o'clock in the morning.
Chicago, oh my goodness. My sister lives in Chicago, so you're invited to have an American coffee there.
I will do that.
But by the way, next time you'll be with us face to face.
Yeah, and, I hope so.
We have Professor Awad Taghiddin is inviting you on behalf of the Ministry of Health. He's the one promoting the COVID vaccination, and it's becoming compulsory in Egypt. So
that's good. In Austria as well.
It's very safe that you join us in Egypt. Hopefully.
Yeah, inshallah. I would be very happy to. Yeah.
And please join us for the coffee break. Bye-bye.
Thank you so much. Bye.
Bye-bye. يا شباب بعد ربع ساعة هنجتمع تاني عشان بس نتعشى بدري والنبي، عشان اللي بيجي له جرد ولا حاجة ما يتعبش بالليل. هنبتدي the second session. I have the pleasure to introduce Professor Martin Colton. هو Professor in Respiratory Medicine and Director of the Division of Respirology, McMaster University, Hamilton, Ontario, Canada. He's not present في Zoom دلوقتي, لكن he's gonna share with us the panel discussion. It's a recorded lecture presentation, and we can start it now.
Zero. Hello and good evening to Egypt from Canada. I'm having the privilege today to talk to you about idiopathic pulmonary fibrosis, evolution and diagnosis and management. Too bad we cannot meet in person, but we will do this at a future time. The field of IPF and interstitial lung disease, and I'm grateful for Boehringer Ingelheim to facilitate these educational events. Let's get started with a patient presentation. This is a gentleman I saw 3 years ago, 58-year-old man who was short of breath on strenuous exertion. He had some cough. He had no other symptoms, crackles on exam, and his lung function showed a mild impairment to an FVC of 77% predicted, normal oxygen. He had really an unremarkable past medical history, did not take any drugs that were suspicious for interstitial lung disease. He had no exposures, was a lifetime non-smoker. I'll show you 2 slices of his high-resolution CT scan here. And if you take a few moments to look at the abnormalities, you will likely agree that there is some reticulation, some areas that look like ground glass, they are very small. the abnormalities are in the periphery, but also go into the central areas of the lungs along the airways. And so this picture would, by most experts, be called indeterminate for UIP. We could talk about that in a little bit. And this would be, given the age of this man, also be someone where we consider biopsy to make a diagnosis. Now, this was offered to this gentleman, but he did not want to pursue. He then did not come for follow-up for 2 more years until June last year, when he had similar clinical presentation, but his shortness of breath got worse. The cough was unchanged. He still had crackles, and his FVC was now 70% predicted. There was an absolute loss of 440 milliliter in 2 years. He had normal oxygen at rest, but he did desaturate slightly. And then he was showing this CT image, where you now see that it's really much more reticulation. There's no ground glass opacity anymore. You see clearly the development of traction bronchiectasis, particularly in the right middle lobe and in the left base. And you see areas that some people would describe as honeycombing, others as traction bronchiectasis and bronchioloectasis. But with this picture, he certainly will be either in the definite or probable UIP descriptive pattern, and you would now diagnose IPF. This man was then put on antifibrotics. He chose nintedanib over pirfenidone because he did not like to take pills at all. So the pill burden with nintedanib, as you know, is just 2 pills a day. With pirfenidone, could be up to 9 pills. And he did reasonably well, tolerated it well. Early December, he had no change. We could not do a spirometry because of COVID restrictions. And then just about 1.5 weeks later, he worsened and came back. His breathlessness was there at rest. His oxygen saturation, 84% at room air. He had no fever, and viral nasopharyngeal swabs, including COVID, were negative. And now this is his CT scan at that time. And you see 2 major elements. The one is the underlying fibrosis, very similar to the picture from earlier that year. And this gets amplified by the presence of patchy ground glass opacities. These ground glass opacities are somewhat in the area of fibrosis, but not exclusively. And this gave him, obviously, the diagnosis of acute exacerbation. He was treated with intravenous solimedrol. He was put on a ventilator because this all happened so quickly, and he was young and did not have any comorbidities. But sadly, the gentleman passed away with acute respiratory failure just 2 weeks after presenting with this event. Now, this is a typical case with a sad ending, and I have a few patients here on this picture. All of them now sadly have passed away because of IPF, and they have a few questions when they come to us in the clinic. So obviously, this gentleman here wants us to be sure. So because he reads about this disease, he reads about the poor survival rates, and he says, well, doctor, you better be sure about this. Now, once a patient has accepted and we have made a final diagnosis, they will ask, is there anything that makes them live longer? And at some point, because we know that existing therapies still do slow down the disease progression, but don't stop it. So eventually patients will get worse, and they will ask about symptom management, and just they want to feel better. Let's just go systematically through these 3 points: diagnosis, prognosis, therapy, and comorbidities. So diagnosis and prognosis is very important. You know that IPF is a debilitating lung disease with often a fatal outcome. It is characterized by progressive scarring in the lungs, particularly in the periphery. The lungs shrink. There will be an impairment of gas exchange, and this disease can be accentuated by acute exacerbations, as I just described to you. It is not the most common disease you will see in your practice, but if you look at the patient population, that is the elderly ones, and this is increasing in size everywhere in the world, in that population, it is a quite common disease, in fact. It is more common than asthma in the patients who are older than 60. And we still don't know what causes it. It's affecting men more than women, and there are different risk factors for it, such as cigarette smoking, for instance. We have learned quite a bit about the pathogenesis in the last 20 years, and you can see these elaborate cartoons in different review papers. I like this one because it breaks down the different areas, which are epithelial cell injury and repair, or the lack of repair. There is some autoimmunity, immune activation, particularly involving macrophages. There is some activity of the coagulation cascade, not so much in regard to blood clotting, but to activation of growth factors. And these growth factors finally stimulate fibroblasts to grow, to proliferate. They will inhibit fibroblasts from undergoing apoptosis, which all results in increased matrix formation and scar tissue accumulation. Clinically, we also learned a lot in the last 20 years. You see here a chart that shows the number of clinical trials that were done since the late 90s. And the bigger the circle here, the more patients were in these trials. You will be aware that only 2 drugs were approved in that time span. So a lot of these trials were negative, but we learned from negative trials as well, because we can learn about the natural behavior of the disease. One important finding of this natural behavior is that we learned that a patient with IPF on average loses about 200 to 300 milliliter FVC per year. The patient I introduced my presentation with lost about 440 milliliter in 2 years, so he's right at this curve that I show you here. A healthy subject by aging would lose about 10% of that. So you may lose 30 milliliters in a year, 25 maybe, but you would not lose 300 or 200. So it's a 10 times accelerated shrinking of the lungs. And you may think that 200 milliliters in 1 year is not that much, but if you just add that year by year, you will, after 5 years, have lost way more than 1 liter in your forced vital capacity. Just at the side, we talk about IPF today, but this is not the only fibrotic lung disease. In fact, in a specialty clinic such as ours here, we would see many other disorders in these ILD clinics. About a quarter of what we do is IPF, which means 3/4 are other types of fibrotic interstitial lung disease. And you see here on the left side a breakdown estimate from a review article published a few years ago. And on the right side, we see real life numbers from our Canadian registry, where we follow more than 4,500 patients by now in a prospective manner. There are a number of documents out there that would give you good guidance on what to do, how to approach a patient with interstitial lung disease, how to make a distinction between different types of interstitial lung disease. And these are very important documents. This is a Canadian Thoracic Society position statement, which is, I think, a very pragmatic one, and you can get this paper through the internet for free. Ultimately, we want to give the disease a name, and there are more than 200 types of interstitial lung disease. And with giving the disease a name, we try to understand its disease behavior, and we try to understand what to do with these patients. If I make that a little bit more simple here, once you suspect fibrotic interstitial lung disease, you have to do a comprehensive history, physical exam, of course, get PFTs, gas transfer, do some serology, and you need a high-resolution CT scan. In the ideal world, you don't do this on your own because it's such a complex topic. You do that ideally with a multidisciplinary discussion. And that would mean you are ideally with another person who is an expert in this field, and you would have an expert chest radiologist. Of course, ideal is not always available, particularly in smaller hospitals, but it's still the gold standard. Now, if you break down these complex disorders into 3 pillars, you would see in the middle one, IPF. If you diagnose that, we know now very well that immunosuppressants are not useful and they may be even harmful. Antifibrotics are the standard of care. If you diagnose hypersensitivity pneumonitis, like on the left side, you would counsel a patient about exposures, avoid them. You would consider immunosuppression, and you would in the future also consider antifibrotics. And if you diagnose a patient with autoimmune disease or connective tissue disorder, you would also consider immunosuppression at first, and in the future for a subset also antifibrotic. So making a diagnosis and making this effort of a multidisciplinary discussion really impacts the way how you manage your patient. Let's talk a few moments about imaging, because this is really crucial and you have to be really confident about reading high resolution CT scans of the chest if you're working in this field. And ultimately you want to describe the pattern of the image in front of you. And there are good descriptors here in this article about typical usual interstitial pneumonia pattern, a probable UIP pattern, an indeterminate pattern, or a pattern that speaks for something else. This is the typical UIP pattern, where you see the reticulation in the periphery of the lungs, you see bronchiectasis, you see honeycombing, and you don't see anything like major ground glass opacity or confluent opacity. If you think these spots in the red circles are the lower right or ground glass opacities, you're correct, but these are in areas of fibrosis, and that doesn't mean it's ground glass the typical way. It means it's just intralobular fibrosis, so very important to see. Now, we have these pictures that are indeterminate for UIP, and this picture is a good example for that. You see the reticulation, you see some ground glass, you see some peripheral involvement, you see some peribronchial involvement. And this is now the patient where you would always consider to do a biopsy if there's no contraindication to aid your decision. What type of biopsy should you do? Yes, the gold standard is still the surgical lung biopsy, because that's the only way how you get a nice big piece as shown on this image. And a pathologist can nicely look at the different features and the patchiness. If you do a transbronchial biopsy, you may just get a few spots that are meaningless. You may get normal lung tissue, or you may get tissue that's just fibrotic without seeing any of the fibroblastic foci, for instance. Cryobiopsy might be an intervention for the future, because it gives you a bigger piece of tissue where you can look at the patchiness, but so far, I think this is a tool that is primarily of use in expert centers, and we still have to see if this is something that is of broader use for smaller hospitals or groups. I have the sizes of the biopsies here. So transbronchial, obviously very small, cryobiopsy is the middle, and the surgical lung biopsy on the right. And one thing that is also coming up now and may affect us in the future is that you go away from looking at the typical histology pattern of UIP to a molecular pattern that reflects the presence of this histological pattern. You can do this with what is called a genomic classifier. So this is molecular profiling, basically fingerprinting of the molecular mechanisms that are active in a given lung. And this seems to be quite helpful and robust in identifying this pattern. It is a tool that is available for clinical use in the United States. In Canada, we don't have it yet. And the good thing is you would just need transbronchial biopsies and nothing else, which is obviously less invasive than the others. Just give you another brief patient example here. So those are two individuals who were presenting to me with a question, do they have IPF? They were a married couple. This gentleman with the tie is my rheumatologist because we see patients together. Now, the man here complained about shortness of breath, dry cough. He had some pain in his joints, in the fingers, wrist. He had questionable Raynaud syndrome, crackles on exam. His skin on the hands was dry and discolored and cracked, so it looked like mechanics' hands, but he actually worked in a steel factory, so he had a good reason for having laborer's hands, and he was an ex-smoker. His autoimmune workup was negative. And again, just take a few moments to look at this picture. You will see reticulation in the periphery. You will see no ground glass opacity. You will see a few larger cystic areas in the bases, which are not the typical honeycombs. They are probably a part of honeycomb, part of bulla, because he was a smoker. But this is a probable UIP pattern, at least. This man was diagnosed with IPF and treated accordingly. Now, his wife presented very similarly. Dyspnea on exertion, dry cough. She had no aches in her joints or muscles. She had crackles. She complained about dry mouth, no dry eyes. She was a never smoker. And her autoimmune workup was not unremarkable. It showed an ANA positivity with SSA, SSB, and a rheumatoid factor being positive. Now, her image is here. Again, you will see reticulation in the periphery, but not exclusively. There is some central areas that are involved. And you see some ground glass opacity as well. Not very dominant, but it's there. Now, this would be an indeterminate for UIP pattern. And this lady would typically be considered for lung biopsy because of her serological abnormalities and the dryness in her mouth. We did a biopsy of the lips, excuse me, and this showed lymphocytic infiltration and gave a diagnosis of Sjögren's syndrome, so connective tissue disease related ILD. Always keep in mind that this pattern of UIP is not synonymous with IPF. Yes, it's the prototypical disease for this pattern, but it can come in different autoimmune diseases, in drug toxicity, asbestosis, for instance, or chronic hypersensitivity pneumonitis. So always make a distinct diagnosis and don't skip even a single step in this process because it's important for your patients. What about the survival of patients? Sadly, this is still true what you read on the internet. About 50% of patients die within 3 to 5 years. We will likely see these numbers improve after the approval of antifibrotic therapies, but there's not yet a good epidemiology study that I'm aware of that would show that, but this will certainly come in the future. This puts the survival of patients with IPF in the same category as a lot of malignancies. In fact, only lung and pancreatic cancer are having a worse 5-year survival rate than IPF. Let's talk about therapy. So what should we do with these patients? The standard of care for IPF is the use of antifibrotics and anti-acid medication. Immunosuppressive drugs at a higher dose should not be used. This has been summarized in treatment guidelines. These treatment guidelines are endorsed by international societies, and they are updated on a regular basis. They basically give you the reasons why you should use certain interventions and why you should avoid other interventions. Reflux medications are in this recommended category, and this is not based on a randomized controlled trial like for the antifibrotics. It's based on observational studies that suggest that patients on anti-acid medication, could be a PPI, could be a H2 blocker, seem to do better and have longer survival and less exacerbations. We looked at this in the placebo arms of the pirfenidone trials and looked at patients who were on placebo and on anti-acid medication or not. And you don't see over this 1-year observation period that there's any difference between the therapies. There are some more cases of infections in patients with excessive PPI treatment, but this is something we know from the ICU as well. The true antifibrotics are called pirfenidone and nintedanib, and you will have seen these curves with the slope of lung function loss over a 1-year period. And both these interventions reduce the loss of lung function by about 50%. It means it goes down from 200 to 300 milliliter per year to 100 to 150 milliliter per year, which is great because it slows down the progression, should affect mortality. But it's still not everything because it's still 5 times quicker than aging would do. Pirfenidone is a small molecule that's been around for a longer while than nintedanib. It interferes with fibroblast function. It's not exactly clear how it does that, but it certainly has been shown numerous times that it does it. And the pirfenidone trials had enough patients in there to show a very clear signal in terms of survival improvement. So it was a very important study that demonstrated that if you affect the loss of lung function measured as FVC over time, you will affect mortality. So mortality is going down. That says that FVC measurement is a surrogate for mortality. The pirfenidone trials also have shown that patients who are treated with this drug have fewer respiratory-related hospitalizations. Again, a very important finding, because it shows that if you treat patients with antifibrotics, they will stay out of the hospital, which means they will have improved quality of life overall, and they will, in the end, cost less to the healthcare system because a hospitalization is costly. Nintedanib is also a small molecule, a bit bigger than pirfenidone, and its molecular activity is better determined. It interferes with growth factors. It's a tyrosine kinase inhibitor, so it targets fibroblastic foci and fibroblast proliferation in particular. For the nintedanib trials, we have a lot of knowledge as well. For one, you see, for example, that the antifibrotic effect doesn't take long to kick in. And after 3 months in the trials, we saw that there was a significant difference between patients on placebo and nintedanib. Now, do not misinterpret this and apply it to an individual patient because you cannot do it. This is applying only if you have a group of 600 patients. When you see this difference, your patient would not be expected to have an effect after that short period of time. So give it long enough time before you consider switching these drugs. One important finding that we learned from the IMPULSIS trials was that this effect is present regardless of the severity of your disease. So you can have patients with preserved lung function, so larger than 90% predicted FVC, or less, and it works the same way. So you'll affect the loss of lung function just the same way if you have a patient with mild or moderate disease. It's also continuing over time. So you see in the IMPULSIS ON study, this was published in Lancet Respiratory Medicine, that you do not lose the effect. So patients who tolerate the drug long-term, they have the same decline of lung function over 3 to 4 years. And this would be here 350 milliliter at the end of this curve. These patients would have lost about 700 to 800 natural disease progression otherwise. If you have a patient with emphysema or not, that's often a question that comes up. It also does not matter. If you have emphysema, you lose lung function when you have IPF, and intervention with nintedanib helps you reduce this lung function loss. Does it work for patients with advanced disease? And we addressed this in this study called the InStage trial, which was looking at nintedanib in a patient group with advanced IPF as determined by low gas transfer. And we added sildenafil or placebo because we wanted to know if this is a safe intervention as well. Long story short, you see 2 important findings. For one, the patients in this InStage trial, severe IPF, compared to the patients in the IMPULSIS trial, moderate to mild IPF, had the same loss of lung function after 6 months. So it works in this patient group. It's safe in that patient group. And it also showed that addition of sildenafil almost stopped the lung function decline over the 6 months period. That means that you can safely consider using sildenafil. It's not approved for this indication, but it is a drug that may have a role in the future. If you use nintedanib pirfenidone in the real world, you will have noticed that the side effects reported in the clinical trials, such as diarrhea, nausea, weight loss, and skin rash, also occur. You will also have seen that dangerous side effects are not very common with these drugs, and this means they can be safely given for long term, but you need to monitor them, of course. In my clinic, the adverse effect profile often determines if I use one drug over the other, and there are certain distinctions. So nintedanib typically causes diarrhea, and this can be managed in most cases, but sometimes it's too much for a patient to take. Some nausea, appetite loss can come with both drugs. Skin rash, dizziness, and fatigue is more common in patients treated with pirfenidone. Always ask your patient if they want to be treated, and don't make the determination yourself. I always ask any patient that I diagnosed with if they want to consider antifibrotics. I explain what they do. I explain what side effects they have. And the patient in the end will make a decision together with the physician. But patients on average like to try these drugs, and if they want them, then they often can cope with side effects much better. Given the fact that the disease is only slowed down, not stopped, and the side effect profile is unpleasant, there is a clear need for developing new drugs. And there are numerous pharmaceutical companies that are working in this field. In this complex slide here, you see the biology of fibrosis at different levels: alveolar, interstitial level, matrix accumulation, fibroblast proliferation, and you see with these abbreviations different drug compounds that target these different areas of biology. You can imagine that a complex disorder like this is not healed with one drug, so you will eventually need more drugs than one. So we have a lot of candidates that are currently in a phase 2 or phase 3 clinical trial. This paper is a review article that I wrote, which is available very soon. And you see here that list of different trials that are in clinical phase trials right now. So hopefully 1 or 2 of these will make it through, and then we'll add to our medication list for this bad disease. Just a few moments about symptom management, comorbidities at the end. You will be aware of those debilitating symptoms: shortness of breath, we talked about; cough, we briefly talked about; deconditioning, loss of appetite, loss of weight, and of course, anxiety and depression. So you can help with different things here. Oxygen therapy is very important. It improves quality of life in patients with pulmonary fibrosis. And you should consider, when a patient is hypoxic at exertion, to give them oxygen because it helps them to live their lives better. If a patient has a lot of anxiety, particularly in advanced stages, do not be shy of using benzodiazepines or low-dose morphines, which are still drugs that many physicians, even respirologists, believe are not safe in patients with chronic conditions. That may be more true for patients with COPD who retain carbon dioxide, but IPF usually does not do that. So they can be used, and patients will be grateful if you take the breathlessness away. Now, we talked about antifibrotic medication, which is a very important element of management of IPF, but I also talked about reflux management. We did not talk about transplant referral because that's really applicable only to a selected few. Don't forget psychosocial support of both the patient and the caregiver. Vaccinations are crucial. We have learned that with COVID now, so we make sure your patients are getting the vaccine. make sure patients get properly nutrition and do exercise, ideally in a rehab program, but if not, give them oxygen so that they can stay active and lead a reasonable life. Now, standard of care for IPF in the past, as you know, was immunosuppressive drug, triple therapy. This is a clear no now because we have shown that this is dangerous for patients and doesn't work. The current standard of care for IPF is a no to immunosuppressive drugs, a yes to antifibrotic drugs, pirfenidone, nintedanib, and a yes to antacids. The standard of care in the future is hopefully combination therapy. We may have nintedanib, pirfenidone still around at that time. We still have antacids probably. We will have another compound X, Z, or Y hopefully, and we will combine them in order to stop this dismal disease from progressing. And this is the end of my presentation, and I will be available now in person and live to answer your questions. Thank you very much.
Thank you, Professor Martin, and we'll keep the questions at the end of the session. We have two other presentations, so please be with us because there'll be some questions after the talks. And may I invite now Professor Mohammed Zidan. He's Professor of Pulmonology in Alexandria University. And Professor Zidan is going to give his talk about what's new in interstitial lung disease, a look into the future. تفضل محمد.
شكرا. بسم الله الرحمن الرحيم. بداية أحب أشكر شركة بورينجر إن أتاحت لي الفرصة إن أنا أكون موجود مع حضراتكم النهاردة. شرف كبير جدا إن أنا أكون موجود وعلى المنصة قامتين كبار جدا في مجال الأمراض الصدرية على مستوى الشرق الأوسط والعالم العربي. معالي الوزير الأستاذ الدكتور عوض تاج الدين واستاذنا الفاضل الاستاذ الدكتور طارق صفوت اللي انا بسميه برنس الامراض الصدريه. وان احنا استاذ الدكتور طارق صفوت يعني احنا بنتعلم منه على المستوى الانساني، يمكن اكتر كمان بنتعلم منه على المستوى المهني. فده شرف كبير جدا ليا ان انا اكون موجود مع حضراتكم. يمكن الكلام اللي كان قبل كده كان مني على الايديوباثيك بالمونري فايبروزس والنيو تريتمنت اوف ذا ايديوباثيك بالمونري فايبروز. ده كان مني على اساس ان كل الاستاديز بينت انه ده one of the diseases اللي هو not responding to corticosteroids with very bad prognosis. المورتاليتي ريت بتاعته عاليه، اعلى من كل المالجنسيز، يمكن ما يسبقوش غير الكانسر لانج والكانسر بانكرياس as regard the mortality. طب what about the other interstitial lung diseases؟ احنا عارفين انه interstitial lung diseases ليها ترم اوسع واعم بنسميه diffuse parenchymal lung disease. More than 200 diseases. Group of diseases where there is lack of parallelism between signs and symptoms, which mean that the patient will be presented with exaggerated symptoms, but after examining the patient, there is no or minimal signs. That's why in order to diagnose such patients at an early stage, you have to have what is called a high suspicion index. And this is a real challenge for the physician. وده اللي بيخلي العيان يمر على 2 أو 3 أو 4 دكاترة ويضيع سنة وسنتين لحد ما نوصل للتشخيص المظبوط. Generally considered rare، وإن كنا مؤخرا بنلاقي مع الانفستيجيشنز اللي بدأت تتطور بنشوف حالات أكتر about 60 to 80 cases per 100,000 people with some interstitial lung disease are associated with early mortality ومن ضمنهم الإيديوباثيك pulmonary fibrosis. الكلاسيفيكيشن احنا عندنا كلاسيفيكيشن العادية بتاعت diffuse parenchymal lung diseases اللي هي ممكن عندنا جزء اللي هو الإيديوباثيك interstitial pneumonias اللي من ضمنه الاي بي اف اللي ليها اليو اي بي باترن زي ما الاساتذه الافاضل اتكلموا في السي تي. عندنا حاجات ممكن تكون secondary to occupations، ممكن تكون حاجات secondary to drugs، ممكن تكون حاجات secondary to connective tissue diseases، في other systemic inflammations، في حاجات زي الليمفانجيوميماتوزس والساركويدوزس بنعتبرهم انتايتي لوحديهم. لكن فعلا السبيكترم بتاع الديزيز ده كبير وواسع. دي الاتيولوجيكال كلاسيفيكيشن. لكن ابتدينا دلوقتي ليتلي نتكلم على كلاسيفيكيشن مختلفة. ايه هي بقى؟ البيهيفير. يعني ايه؟ يعني احنا عارفين ان حاجه زي الايديوباثيك بالمونري فايبروزس ذا فيري باد بروجنوز، بس احنا بعض الاحيان ابتدينا نشوف عيانين المفروض انه الانترستيشال لانج ديزيز اللي عنده ليه جود بروجنوزس، بس دي ما بتبقاش الكيس. بنلاقي العيان واخد سكه غير اللي احنا متوقعينها. فابتدينا نتكلم على حاجه اسمها progressive phenotype of interstitial lung disease. يعني ده المينلي الكلام في المحاضره دي على البروجريسيف phenotype of any interstitial lung disease غير الايديوباثيك pulmonary fibrosis. يمكن الاي تي اس والاي ار اس كان لهم كلاسيفيكيشن، كانوا بيتكلموا على reversible وسيلف ليميتد، reversible disease with risk of progression، وبعدين stable disease with residual disease، progressive irreversible disease with potential for stabilization، progressive irreversible disease despite therapy. دول اللي احنا بنسميهم البروجريسيف phenotypes، اللي هو progressive but response to immunomodulation، progressive regardless of the treatment considered appropriate for individual with interstitial lung disease. هو ده mainly الكلام، ان احنا هل الناس دول ليهم امل في النيو دراجز اللي عندنا، التريتمنت الجديده اللي طالعه، هل في امل بالنسبه للناس دول اللي هي ما كانتش المين انديكيشن اللي موجوده في الاساس اللي هي كانت طالعه الايديوباثيك بالمونري فيبروز. فهنا بنتكلم على الفيوتشر as regard the progressive phenotypes of any interstitial lung disease. احنا عارفين انه according to the interstitial lung disease ذات نفسه في certain diseases بتبقى الفايبروزس فيها هو الاكثر، وبيبقى العيان محتاج انتي فايبروتيك ايجنت زي الايديوباثيك بالمونري فايبروزس. في حاجات بيبقى mainly الانفلاميشن اكثر، وبيبقى ليه علاقه كمان بالاكسبوجر زي العيانين بتوع الهايبر سنسيتيفيتي نيمونايتس. وفي حاجات بتبقى mainly انفلاميشن وبيبقى محتاج انتي انفلاماتوري دراجز زي الكونكتيف تيشو ديزيز interstitial lung disease. البروجريسيف فايبروزنج interstitial lung disease in general، احنا بقى ما بنتكلمش على الاي بي اف، احنا بنتكلم على diffuse parenchymal lung disease as general term، follow a similar disease course and the prognosis as that observed with IPF. معناه ايه؟ انه في variable و unpredictable associated with high mortality characterized by a deterioration in lung function and worsening of the respiratory symptoms. بالتالي لازم مش عارف مكتوب في الايدي قدام هؤلاء المرضى، ولازم يكون عندي solution for those patients. زي ما قلنا اي ديزيز ممكن يكون الكورس بتاعه النورمال ان هو يمشي بطريقه كويسه والبروجنوزز يبقى كويس، لكن in certain patients this is not the case, and in many patients بنلاقي انه although the patient is receiving the maximum treatment for his condition, there is still progression of the disease with worsening of the symptoms and worsening of the pulmonary function test, وeven بيبقى كمان في worsening radiologically. لما نيجي نشوف قد ايه من العيانين من كل ديزيز ممكن يكون عندهم progressive phenotypes، هنلاقي مثلا حاجه زي مثلا الساركويدوز، واللي هي المفروض انه اغلب المرضى بتمشي بطريقه كويسه. عندنا about 20% من عيانين الساركويدوزس عندهم progressive phenotype. دول ممكن يبتدي يتعاملوا معامله مختلفه، ويبقى في عندي النيو دراجز اللي موجوده ممكن يبقى ليها رول مع العيانين دول. حاجات مثلا زي الكونكتيف تيشو ديزيز، about 24% of the patient who has connective tissue diseases زي ما حضرت لحضراتكم عندهم progressive phenotypes، ما يمشوش في الكورس العادي بتاعهم. السيستميك سكليروزس طبعا، ودي زي ما هنشوف يمكن تاثير السيستميك سكليروزس على اللنج وعلى الديفيوجن بيبان يمكن من اول سنه من الدياجنوزس. 31% نسب مهمه جدا، واعداد كبيره جدا من المرضى محتاجين a new solution، محتاجين ان احنا نفكر out of the box in order to improve their quality of life. لما نيجي نبص على حاجه زي السيستميك سكليروزس، ودي كانت استادي اتعملت على more than 5800 patients، بنلاقي انه 35% related deaths due to interstitial lung disease and 26% due to pulmonary arterial hypertension. اللي كان بيميز كمان العيانين بتوع السيستميك سكليروزس بالذات انه اللنج انفولفمنت بتبان من اول سنه. يعني مثلا ممكن واحد يكون عنده روماتويد مثلا ويقعد له 20 30 سنه ومفيش اي تاثير على اللنج، بنشوفها كتير جدا، وممكن ما يجيلوش تاثير خالص على اللنج. لكن مينلي الستاديز لما توجهت على السيستميك سكليروزس كان مينلي لان السيستميك سكليروزس بيبان الديفيوجن ديفكت من اول سنه after the diagnosis. بنبص هنا مثلا نلاقي انه عندنا في العيانين السيستميك سكليروزس او العيانين بتوع الروماتويد ارثرايتس بنشوف قد ايه انه العيانين اللي عندهم بروجريسيف فينوتايبس المورتاليتي بتزيد والورسنج اوف ذا سيمبتوم سريع، وبياخدوا كورس مشابه تماما للباترن بتاع العيانين بتوع الايديوباثيك بالمونري فايبروزس. نفس الحكايه بالنسبه للانترستيشال نيمونايتس with autoimmune features. Patients with idiopathic interstitial pneumonia and the clinical feature that suggests an underlying autoimmune process but do not meet established criteria for a connective tissue disease. في جزء كبير جدا منهم بياخد البروجريسيف فينوتايب. طب ايه الريسك فاكتورز لاي عيان عنده اي interstitial lung disease يخليني افكر ان العيان ده when he is presented for the first time بالنسبه لي ان ده ممكن يمشي في السكه اللي مش مظبوطه وممكن البروجنوز بتاعه ما يبقاش كويس؟ الميل حظهم وحش دايما، الاولدر ايج ديفينتلي، lower FVC وديفيوجن ديفكت من البيز لاين، ودي كان الاستاذ دكتور ياسر شرحها انه الديفيوجن مهمه جدا في البدايات لان احنا بنلاقي ناس عندها لانج فوليومز بتبقى نورمال في البدايه، فاللي بيقدر يخليك تعمل الفرق وتعمل توصل للدياجنوزز هو الديفيوجن. الديكلاين في الفورسد فيتال كاباسيتي more or equal to 10% of the predicted، ولما رجعت البيبر دي كانوا بيتكلموا على more or 10% of the predicted في فترة بحوالي من 12 شهر زائد أو ناقص 3 شهور، يعني سنة من 9 شهور لسنة. الناس اللي عندهم يو اي بي باترن في البلمونري فايبروزس extensive traction bronchiectasis، الناس اللي عندهم هايبر سنسيتيفيتي نونايتس ولما نعمل لهم لاباج نلاقي انه الليمفوسايتس بتاعتهم قليله، الناس اللي عندهم سيستميك سكليروزس بنلاقي عندهم حاجه اسمها انتي توبو ايزوميريز انتي بودي، الانتي سي سي بي انتي بودي في العيانين اللي عندهم روماتويد ارثرايتس، والنيجاتيفيتي فور انتي جي او 1 انتي بوديز في البيشنت اللي عندهم مايوسايتس انترستيشال لانج ديزيز. دي فاكتورز لما بشوفها في عيان بتوقع انه ممكن ياخد السكه بتاعه البروجريسيف فينوتايب. ايه اللي يخليني اقول بقى العيان بقى بيحصل له بروجريشن او ماشي بروجريسيف فينوتايبس ولا؟ حاجات كتيره جدا. يعني مبدئيا السيمتومز بتاعت العيان، ما هو السيمتومز بالنسبه لي مهمه. انا كفيزيشن نفسي وجهه نظري في العيان ما انا بشوفه وبتابعه والى اخره. البلمونري فانكشن تيست ممكن تكون السي تي، الكواليتي اوف لايف بتاعت العيان اللي مؤثره على الفيزيكال فانكشن. فانا عندي كذا بارامتر من خلالهم ممكن احكم اذا كان العيان ده هذا بروجريسيف فينوتايب ولا عنده الستيبل فينوتايب فور ذيس انترستيشال لانج ديزيز. لما بنبص في كل الاستاديز اللي اتعملت كانت البلمونري فانكشن تيست مهمه جدا في البدايه. ومهمه ليه؟ مهمه عشان كمان اقدر اتابع بيها العيان، وكان كل الاستاذ بتبين انه الديكلاين في الفورسد فيتال كاباسيتي more than or equal to 10% is associated with higher mortality and more exacerbation and bad prognosis. نرجع لمرجعنا الاساسي، احنا عارفين البلمونري فانكشن تيست is an effort dependent بس ما زالت مهمه جدا سواء في البدايه في الدياجنوزس وعشان اعمل فولو اب للبيشنت، وفي نفس الوقت كمان عشان اعرف اذا كنت الدواء الجديد اللي انا بكتبه للعيان ده جايب نتيجه ولا مش جايب نتيجه، يبقى ليها رول مهم جدا بالنسبه لنا. other يعني factors طبعا منظر السي تي بتاعنا whatever the extent of the interstitial lung disease، العيان عنده ground glass قد ايه، الريتيكولار باترن، الهاني كومينج extent، التراكشن bronchiectasis، طبعا كل ما زاد الهاني كومن وزاد التراكشن برونكياكسس ده بيخليني ابقى عارف ان العيان اوريدي ابتدى يخش في مرحله متقدمه، غير لما العيان يكون عنده جراوند جلاس اوباسيفيكيشن. دايما اقول ان جراوند جلاس اوباسيفيكيشن في العيانين اللي عندهم انترستيشال لانج ديزيز بتعني ان العيانين دول ما زال عندهم ongoing process وممكن يتلحقوا ويرجعوا، بالظبط زي اللي بنشوف في العيانين بتوع الكوفيد، يبقى عنده سي تي مليانه جراوند جلاس اوباسيفيكيشنز وبنشوف بعد شهر وشهرين completely normal سي تي. لكن تو ما لقيت تراكشن برونكياكسس، تو ما لقيت هاني كومينج، معناها ان دي ديد ارياز مفيش امل ان هي ترجع خالص. برضو من ضمن الحاجات اللي تقول اذا كان العيان هيبقى عنده باد بروجنوزس ولا لا هي الاكيوت exacerbation which can occur at any time of the disease، وممكن نشوفها في العيان بتوع الهايبر سنسيتيفيتي immunitis والاسبستوزس. لكن الاكيوت exacerbation او الاكزاسربيشن بتاعت الانترستيشال لانج ديزيز يهمنا قوي ان احنا نقول ان احنا بنتكلم على worsening of the symptoms with new infiltrates في ال CT without the presence of any obvious cause. دي الاكزاسربيشن اللي فعلا مضر. يعني بمعنى ايه؟ يعني لو واحد عيان جالي وكان عنده worsening of the symptoms بس عنده chest infection، مش دي الاكزاسربيشن اللي انا بقصدها. لو واحد عيان جالي وكان عنده worsening of the symptoms نتيجه انه عنده heart failure، مش دي الاكزاسربيشن اللي انا بقصدها. اللي انا بقصدها وبنشوفها كتير جدا في الكلينيكال براكتس، بيجي لي عيان عنده اكزاسربيشن وعنده worsening of the symptoms وما عندوش اي حاجه على الاطلاق تفسر this worsening of the symptoms. دي الاكزاسربيشن، ودي مهمه جدا لان هي بتقلل في البلمونري فانكشن تيست جامد جدا وبتاثر على المورتاليتي. يمكن من ضمن نقاط القوه اللي موجوده في الاستاديز بتاعت النينتادينب ان هم اشتغلوا على الاكزاسربيشن. الكومبيتيتور ما اشتغلش على الحته دي، ودي نقطه في غايه الاهميه انه الدواء يبقى بيشتغل على الاكزاسربيشن. بنشوف عيان ماشي كويس جدا 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 وبيجي له مره اكزاسربيشن بنلاقيه بني ادم تاني بعد الاكزاسربيشن، ما يطلعش الاكزاسربيشن زي ما دخل. Defining progressive fibrosing interstitial lung disease كان في الانبيلد ترايل اللي اتعملت. الانبيلد ترايل كانوا ادوا نينتادينب توايس ديلي وفي ناس خدوا بلاسيبو، والبروجريشن هنا في الانبيلد ترايل كان patient were required to meet more than or equal to one of the following criteria: relative decline في forced vital capacity more than or equal to 10%, relative decline في forced vital capacity from 5 to 10% of the predicted and worsened respiratory symptoms, relative decline في forced vital capacity from 5 to 10% of predicted and decrease the extent of fibrosis في high resolution CT chest, worsened respiratory symptoms and increase the extent of fibrosis on high resolution CT. يعني بنلاقي من ضمن الاربعه كرايتيريا 3 منهم معتمدين على الايه؟ على البلمونري فانكشن تيست، ودي برضو ارجع اقول انه مهمه بالنسبه لنا في العيانين دول. طيب الناس دول كان تقسيمتهم ايه؟ 30% من العيانين دول كان عندهم اوتو اميون انترستيشال لانج ديزيز، حوالي 21% كانوا هايبر سنسيتيفيتي نيمونايتس، في ناس كان عندهم نون سبيسيفيك انترستيشال نيمونايتس، وكان في others interstitial lung disease and uncalcified interstitial lung disease. الانفيلد ترايل مختلفه بقى، دخلت عيانين جداد غير اللي هم كانوا في العيانين بتوع الايه؟ الايديوباثيك بالمونري فايبروز. طب الريزلتس قالت ايه؟ الريزلتس كانت واضحه جدا ان هي بينت انه حصل relative reduction في الديكلاين في الاف في سي about 57% في الاوفرول population. الناس اللي كان عندهم يو اي بي لايك فايبروتيك هاي ريزولوشن سي تي كان relative reduction about 61%. لما نقارن ده بالاستاذ اللي اتعملت في الاي بي اف كانت حوالي relative reduction ب 49%. ده فتح المجال انه في اف دي ابروفل اتاخد يوم 9 مارس 2020 للنينتادينب to be used in all progressive phenotypes of interstitial lung disease. ستادي تانية اتعملت مينلي على السيستميك سكليروزس. وليه قلنا سيستميك سكليروزس؟ لان قلنا انه الريسبيراتوري مانيفستيشنز في عيانين السيستميك سكليروزس للاسف الشديد بتبتدي تبان من اول سنه عكس other diseases. برضو العيانين خدوا النينتادينيب توايس ديلي قصاد عيانين خدوا بلاسيبو، وكان واضح جدا جدا الانيوال ريت اوف ديكلاين في الاف في سي يمكن كان اكتر من النص over 52 weeks compared to الجروب بتاع البلاسيبو. كان في relative reduction about 44%. لما نقارن الريزلتس بتاعه السنسس اللي هي كانت في السيستميك سكليروزس كانت 44%، وقصاد الامبالسز كانت 49%. بقى دي برضه ستادي بتاكد ان those patients with progressive phenotypes اللي انا اديت لهم العلاج اللي المفروض كانوا ياخدوه وما استجابوش and still there are worsening of the symptoms وال quality of life is deteriorating, those patients may benefit from nintedanib in the future. So in order to to conclude, many non-IPF fibrotic interstitial disease behave just as bad as IPF. لان احنا قلنا انه احنا كنا في البدايه بنتكلم على اي بي اف عشان ما بيستجيبش للاميون سبريسيف دراجز وما بيستجيبش للكورتيكوستيرويدز. Biological similarities of fibrogenesis at advanced stages of interstitial lung disease، يعني بيبقى حتى عندهم منظر في السي تي شبه المنظر بتاع اليو اي بي. النينتادينيب data till now show an effect in reducing annual rate of decline of forced vital capacity in non-IPF patients with a similar safety profile as that in IPF. الجملة المهمة اللي قالها البروفيسور في المحاضرة اللي قبل كده ودي مهمة جدا، لازم تعرض الدواء على المريض اللي قصادك، ما تقولش لا هو مش هيقدر عليه. في اوبشن موجود لازم تطرحه على هذا المريض. ولازم دايما واخدين بال حضراتكم لما نيجي نتكلم على دواء whatever the price whatever اي حاجة، لازم نفهم انه احنا as a physicians في ستيتمنت مهمة جدا لازم نحطها في ذهننا. احنا we cannot add a days to a life of a patient لأن الأعمار بيد الله. But we can add life to his days. فأي new drug can add benefit and improve the quality of life of my patient. من واجبي as a physician إن أنا to offer this choice for the patient وعليه إن هو يختار. شكرا جزيلا لحضراتكم.
شكرا جزيلا دكتور محمد على المحاضرة المتميزة، وانت دايما محاضر متميز وشخصيا ان شاء الله بروميسنج باذن الله. الحقيقه الدكتور محمد اثار نقاط مهمه جدا. يمكن النقطه اللي اثارها ويمكن ما خدتوش بالكم منها اتقالت كده في وسط الكلام لما اتكلم على ATS و ARS recommendations، وبدا يتكلموا على ستيج او من الستيجز بتاعت الانترستيشال لانج ديزيز ريفرسبل اند سيلف ليميتد. لو رجعتوا كل الريفرنسز قبل كده كل الليتريتشر بيتكلموا على كرونيك ديزيز بروجريسيف اوف انون ايتيولوجي، ودي مش حقيقه. وانا طبعا هسال الدكتور ياسر والدكتور محمد تاني فعلا از ات irreversible كل الحالات، وبعدين هسالهم تاني هل فعلا unknown etiology؟ لان في حاجات كتير جدا ما اعرفش حضرتك تفتكروا، اكيد الدكتور طارق يفتكر كده لما كنا بنتكلم عن الناس اللي بيجوا لنا بانترستيشال لانج ديزيز بنتكلم على البيجون بريدرز، فاكر يا طارق؟ فكان الستات زمان ما اعرفش انتوا لحقتوا ولا لا، في القرى بيزغطوا الحمام. كانت الست تحط الاكل بقها وتزغط الحمام، فكان بيجي لهم بيجون بريدرز ديزيز. وكان سؤال تقليدي جدا احنا بنساله للناس، خصوصا كان في الوقت ده مور كومن في الفيميلز عكس اللي بيقوله الدكتور محمد. طبعا بعد المجلس القومي للمراه بقى الرجاله يصابوا اكثر الظاهر بالترانسيشن دي. فالمهم فبقى بقى موجود في البيجون بريدرز عشان هم اللي كانوا بيزغطوا الحمام. فكان سؤال تقليدي انت حضرتك عندك حمام في البيت او بتربي حمام؟ وفي ناس كتير قوي كان بيتكلم بقى على ريليتد للبغبغانات والطيور والكلام ده كله. ده كاتيجوري. الكاتيجوري الثاني احنا كنا بنلاحظه في بعض البلاد، يعني مثلا البلاد في الصعيد اللي فيها مصانع قصب السكر، هم بيجيبوا عندهم بيزرعوا القصب، يطلعوا منه سكر ويطلعوا منه عسل اسود، ويفضل المصاصه بتاعت القصب بياخدوها يعملوا منها خشب حبيبي. دي موجوده في قوس وموجوده في بعض البلاد الاخرى. الحتت دي لو حد فيكم يتابع هيلاقي نسبه انترستيشال لانج ديزيز موجوده. كومومبو طبعا بالظبط يا طارق. الحاجه الثالثه، انا اديت محاضره مره على الدراج انديوزد انترستيشال لانج ديزيز، ولقيتهم زي ما كنت بقول للراجل ده 120 دواء. حاجات منهم انكسبكتد، في حاجات كلنا عارفينها، يعني كوردارون مثلا كلنا عارفينه. ولما قعدنا اتناقشنا مع زمايلنا بتوع الكارديولوجي، في طبعا كوردارون از فيري اميلوريدين، مش كده؟ فيري افكتيف دراج كانتي اريزميك، وفيري افكتيف فعلا. لكن انا لما بيجي لي عيان تشيست وبياخد كوردارون انا ببقى قلقان جدا، بقول له تروح للدكتور الكارديولوجي قول له لو سمحت هل ممكن نغير الدواء ده ولا لا؟ طب افرض فعلا ما فيش حل غير انه ياخد الكوردارون. في الحاله دي بقى انا اي كان بريفنت. عشان كده بسال الدكتور محمد والدكتور ياسر، هل الديزيز ده interstitial lung disease is preventable disease ولا لا؟ بريفنتبل، ممكن يبقى بريفنتبل. احنا عندنا الامراض في كل الامراض بما فيهم امراض الصدر، في امراض بريفنتبل وامراض تريتابل وامراض كيورابل، وفي امراض الثلاثه لا هم بريفنتبل ولا تريتابل ولا كيورابل، صح؟ طيب مثلا وهنتكلم فيها دي بعد شويه عشان الوقت، لكن انا بعتقد ان في حالات الانترستيشال لانج ديزيز ممكن تبقى بريفنتبل، في حاجات ممكن تبقى تريتابل، وفي حاجات كمان ممكن تبقى كيورابل. والدليل اللي انت قلته يا دكتور محمد، وانا الحته دي اول مره اسمعها مهمه جدا، انه بدا يحطوا على ريفرسبيليتي في بعض حالات الانترستيشال لانج ديزيز. ده كلام مهم جدا، كلام مهم جدا. يعني كل المحاضرات دي بتتكلم على مرض كرونيك بروجريسيف تريتابل بات نوت كيورابل. وكل اللي انا بعمله ان انا بقلل البروجريشن بتاع الديكلاين في الفورس فايتال كاباسيتي او الاف اي في 1. لكن انا بدل مثلا عام يموت بعد 3 سنين باعمار بيد الله زي ما انت قلت، ممكن بعد 5، ممكن الديسنيا بتاعته تقل، ممكن الكومبلاينس بتاع العين يبقى احسن، ممكن الكواليتي بتاع اللايف تبقى احسن، وهكذا. يعني هنكمل البرزنتيشنز، فاضل لنا يعني اخر سبيكر، وبعد كده انا اعتقد ان احنا محتاجين مناقشه في هذه النقاط. انا قلت اقولها مقدما عشان تحضر الاجابه انت والدكتور ياسر.
انا شاكر حضرتك جدا، يعني اي اضافه حضرتك بتضيفها لنا بصراحه بتبقى حاجه يعني بتسعدنا جدا. انا بس فيما يخص الدراجز، لان دي فعلا برضه مشكله، انا عايز اقول ان احنا عندنا very useful سايت موجود على الانترنت اسمه www.pneumotox.com، عاملاه Department of Chest في فرنسا في جامعه ديجون. الناس دول ما بيشتغلوش غير دراج انديوزد لانج ديزيز، وده موجود بكذا لغه، بيحصل له ابديت تقريبا كل يوم. اي دراج مجرد انه يتحط اسمه على السايت ده هو بيطلع لحضرتك كل حاجه ليها علاقه بال ممكن تبقى تاثر على اللنج. في نفس الوقت زمايلنا بتوع الكلينيكال فارماسي بصراحه ما نقدرش ننكر ان هم اضافوا لنا كتير جدا بالتعاون معاهم، في ان احنا ممكن ان احنا كل ما تطلع دواء جديده مش عارفين ممكن تعمل او ما تعملش. فدي نقطه مهمه جدا as regard drug induced lung disease.
نسالك سؤال يا دكتور محمد عشان زمايلنا كلنا، يعني اكتر دواء بيستخدم في العالم مين؟
اكتر دواء
اللي كل الامريكان بياخدوه؟
اسبرين.
اسبرين. حد فيكم يعرف ان الاسبرين كان induced interstitial lung disease؟ صدق؟
دي ما
ما عشان كده بقول، ففي حالات ريكوردد انها ممكن يحصل لها interstitial lung disease من الاسبرين، وحاجات تانية كتير قوي. طبعا كتير من الاميونو سبريسيف دراجز اللي هي كانت بتستخدم كانتي فايبروتيك بتعمل interstitial lung disease. كتير قوي من ادويه اخرى كثيره بتعمل انتي بايوتكس، انتي كانسر ميديكيشن. مره نبقى نعمل ميتنج مخصوص عشان دراج انديوست لانج ديزيز. اخر سبيكر دكتور محمد سعيد، اظن هيعمل كيس برزنتيشن. موجود؟ مش موجود؟ اتفضل يا دكتور محمد.
السلام عليكم.
عايز اقول للدكتور محمد سعيد بروفيسور اوف بالمولوجي كايرو يونيفرستي.
شكرا لحضرتك يا فندم.
دكتور محمد سعيد هيعمل اللي هي انتراكتيف سيشن
تمام حضرتك.
وفي كيو ار كود موجود على الترابيزات، بس احنا ما عندناش هنا امريكا كيو ار كود. ده موجود ايه في ظهر طيب الكيو ار كود ده عشان نطلع الاسئله تقدر تعرف الاجابات الصح من الغلط، مش كده؟
اديله معلش، هي بس المحاضره هنا مختلفه عن البرزنتيشن، مختلفه عن السكرين. حاضر يا فندم. في البداية بحب أشكر شركة برينجر على اليوم العلمي الجميل ده، وشرف ليا إن أودي محاضرة قدام حضراتكم وقدام أساتذتي الدكتور محمد عوض والدكتور طارق صفوت. ده شرف كبير ليا يعني. إن شاء الله مش هطول على حضراتكم، أنا عارف إن حضراتكم ممكن تكونوا تعبتوا من اليوم الطويل. هتكلم النهاردة على some interstitial cases من وحدتنا، وحدة الديفيوز بارنكايمال لانج ديزيز في القصر العيني اللي بيرأسها أستاذي الدكتور يسري عبد. هو بقلب من هنا ولا حضرتك بتقلب؟ كليك من هنا؟ لا مش أنا اللي بقلب. حاجة كده كليك. بس كده. طيب خلاص. أول حالة عندنا هو male patient 64 years old working as a farmer, ex-smoker من 14 سنة, used to smoke 2 packs per day for 30 years. كان جاي لنا complaining of dyspnea of 2 years of duration of progressive course, not known to be diabetic or hypertensive. On examination, respiratory rate was average, heart rate 90 per minute, saturation 94 on room air, and after exertion حصل له desaturation. المينيمال oxygen saturation after exertion كان 89. كان عنده digital clubbing. Chest examination showed bipaslar crackles. 6-minute walk distance كان 315 meters. وده شكل الهاي ريزوليوشن سي تي اللي اتعمل له upon admission. يعني أتمنى إن الصورة تكون واضحة. What is your diagnosis from this high resolution CT? definite UIP, probable UIP, indeterminate for URP ولا not UIP. حاضر يا فندم. احنا كان راينا في الوحده ان هي definite UIP عشان ان هي subplural وبيزل وبايلاترال، وفيها اهم حاجه تميز اليو اي بي هي الهاني كومبينج. والهاني كومبينج دي هي الهول مارك فيتشر اللي بتبقى موجوده في الهاي ريزوليوشن سي تي، اللي بيها اقدر اشخص العيان ده ان هو هاف اتش ار سي تي فيتشرز اوف يو اي بي. زي ما الاساتذه الافاضل اتكلموا عن الاتش ار سي تي فيتشرز فور diagnosis اوف يو اي بي، سواء كانت اي بي اف ولا يو اي بي secondary to any other cause، لازم الاقي subpleural and basal and honeycombing. لو لقيت بدل الهاني كومبينج ريتيكوليشن كده تبقى probable. لو ما لقيت very fine reticulation مع جي جي اوز بتبقى indeterminate for يو اي بي. لو لقيت other features او other distribution of these lesions كده ببعد تقريبا تماما عن اليو اي بي وبخش في alternative diagnosis. الهاني كومبينج هو كلاستر سيستيك اير سبيسز، بتبقى افريج من 3 ل 10 ملم، لكن ممكن تبقى واخده حجم كبير up to 3 سنتيمتر. What to do next for this patient؟ معظم الاسئله ما فيهاش correct answer، هي فيها most appropriate answer according للاكسبيرينس بتاعت حضرتك والاكسبيرينس بتاعت السنتر الامكانيات بتاع المكان اللي احنا شغالين فيه. measurement of serum precipitating antibodies, laboratory testing for collagen vascular disease، ولا اعمله لافارج ولا بي ان سي ولا all of the above؟ for this patient يعني احنا شايفين ان احنا طبعا لازم نكسكلود كولاجين فاسكولار ديزيز، عشان زي ما حضراتكم عارفين عشان اشخص يو اي بي اي بي اف لازم اكسكلود كونكتيف تيشو ديزيزز كونكتيف تيشو ديس اوردر. البرونكا الفيورال لافاج ممكن يبقى ايه ديبيتابل شويه، يعني هي الليتست جايد لاينز قالت لو الاتش ار سي تي تيبيكال فور يو اي بي ممكن ما تعملش برونكا الفيورال لافاج. العيان ده فارمر وعايش في بلدنا، واحنا الموست كومن انترستيشن لانج ديزيز اللي لقيناه كان الهايبر سنسيتيفيتي نيومونايتس، فبرضه ديبيتابل او اوبشن ان انا العيان ده ممكن اعمل له سيرم بريسبتيتنج انتي بوديز تو اكسكلود اتش بي او فارمر لانج. العيان ده لو عملنا له برونك الفيورال لافاج وكان الفلويد اناليسيس بتاعه شوينج الفيورال ماكروفيجز 62% والنيوتروفيلز 30% والليمفوسايتس 5% والايزينوفيلز 3%. البال فاندنجز دي ماشيه مع يو اي بي اي بي اف ولا فايبروتيك اتش اي بي؟ هي تمشي اكتر مع يو اي بي اي بي اف لان ما فيهاش انكريز في الليمفوسيتيك كاونت، والابسنس اوف lymphocytic انكريز في البال فلويد اناليسيس بيكسكلود الى حد كبير الهايبر سنسيتيفيتي نيومونايتس. Do you think expiratory film HRCT will be of value in this case? Yes or no? طيب هي الإجابة يس. والاكسبيراتوري فيلم في الهاي ريزوليوشن سي تي بروتوكول ده المفروض يتعمل في أي عيان بريزنتنج لينا بديفيوز بارينكايمر لانج ديزيز، ومفروض الاكسبيراتوري فيلم في البرون والسوباين بوزيشن المفروض يتعمل في كل العيانين عشان اكسكلود اير ترابنج ونديفرنشيت مثلا الاتش بي من ساعات كتير عيانين بالمونري هايبرتنشن بيجوا بالموزايك باترن اللي شبه او بتبقى مورليس تيبيكال للاتش بي، فالاكسبيراتوري فيلم ده بيفرق ان الاير ترامنج الحتت السوداء بتزداد سوادا على عكس البالمونري هايبرتنشن. لو العيان ده عملنا له سيرجيكال لانج بايوبسي وكانت دي الباثولوجيكال فايندنجز بتاعتنا في absence of bronchial affection and absence of bronchocentric inflammation، كان في many fibroblast، ما كانش فيه جرانيلوما، كان heterogeneous، وكان في loss او distortion للnormal parenchymal architecture. These pathological findings confirms the diagnosis of UIP IPF or fibrotic HB. الكلام ده طبعا مظبوط. اهم حاجه في الباثولوجيكال فايندنج في عينين اليو اي بي هو اللوس اوف نورمال بارينكايمر اركتكتشر، ويبقى فيه هيتروجينيسيتي في الباثولوجي، بيبقى فيه نورمال لانج ارياز مع ارياز ثانيه كومبليتلي افكتد، ويبقى الديستريبيوشن بتاعها بيبقى سب بلورال، ما بتبقاش برونكلوسنتريك زي عيانين الهايبر سنسيتيفيتي نيومونايتس. diagnosis of IPF زي ما قلت لحضراتكم، نمره واحد exclusion of other causes of interstitial lung disease، نمره اثنين ان انا اعمل high resolution CT وتبقى فيها typical picture بتاعه اليو اي بي، نمره ثلاثه لو فيها probable او indeterminate او alternative diagnosis ساعتها بضطر ان انا اخد بايوبسي من اللنج سواء كانت برونكوسكوبيك او surgical lung biopsy، وابتدي اعمل combination between ال high resolution CT finding والباثولوجيكال findings بتاعت العيان ده. Pulmonary function test for this patient, spirometry with diffusion showing forced vital capacity can 67.8% and FEV1 can 70% of 2.28 liter absolute value and DSO can 50%. حضراتكم عارفين الجاب سكور ده physiological score for assessment of patients with IPF to predict the prognosis and outcome and the mortality of this patient. Yes, according to the GAP score, this patient goes into category 2 or stage 2. GAP score, G for gender, female or male, A for age, and P for physiology, FVC predicted percent, and DLCO predicted percent. What is the most appropriate therapy for this patient? UIP, IPF, GAP score 2 ما عندوش comorbidities تخوفنا. Antifibrotic, bosentan, acetylcysteine, prednisolone and azathioprine، ولا supportive care وما ادلوش اي specific therapy. Yes, this patient is indicated for antifibrotic سواء كان البرفينيدون او النينتدينيب، لان البيشنت ده يو اي بي اي بي اف ومتشخص بالهاي ريزوليوشن سي تي، وعملنا exclusion of other causes of interstitial lung disease. Case number 2, male patient 39 years old, ex-smoker 3 years ago, used to smoke 1 pack per day for 17 years, complaining of dyspnea of 3 years duration or progressive course. لكن كان mild progressive course associated with dry cough, no family history of interstitial lung disease, not known to be diabetic or hypertensive. وده كان physician كان دكتور أشعة على ما أتذكر. On examination, respiratory rate normal, heart rate كان normal, saturation كان 96 on room air with minimal saturation 91 after exertion, و 6 minute walk distance كان 350 متر، والبيشنت ده كان not known to have any chronic illness أو disease. كان عنده digital clubbing لكن كانت يعني first degree، وكان برضو عنده bipassal crackles. ده كان الهاي ريزوليوشن سي تي بتاعه. ان شاء الله تكون الصوره واضحه لحضراتكم يعني. سؤالي الاولاني، your diagnosis from this high resolution CT definite ولا probable ولا indeterminate ولا not UIP؟ بصراحه هي السي تي محير شويه ما بين definite UIP و probable UIP. لو في bilaterality وفي بيزل وسبلولر وفي الهانيكومبينج، لكن ممكن يبقى فيه شويه جراوند جلاس appearance. لكن بعد المالتي ديسيبلينري ما فيش حاجه صح، ما فيش اجابه صح، دي كلها حاجات من واقع خبرتنا وشغلنا يعني. بعد المالتي ديسيبلينري ديسكشن اتشخص عندنا ان هو ديفينيت يو اي بي وسنه صغير كمان يعني. البلمونري فانكشن كيست كانت فير، يعني كان عنده مايلد ريستريكشن وكان عنده مايلد امبيرمنت في الديفيوجن، والعيان ما كانش بينهج قوي يعني. زي ما حضراتكم عارفين، اي patient suspected to have interstitial lung disease او idiopathic pulmonary fibrosis يجي الاول ناخد history يعني prompt history about his environmental exposure في البيت وفي الشغل، وده مهم جدا جدا جدا، لان بنتعرض لانتيجنز كتيره في حياتنا في الشغل وفي البيت بتؤدي الى hypersensitivity pneumonitis، وده شفناه من شغلنا. واساله كمان على السموكينج هيستوري، وابتدي اشوف بعد كده غالبا بحتاج هاي ريزوليوشن سي تي، واكوردنج للفيتشرز اللي موجوده في الهاي ريزوليوشن سي تي. وبعد المالتي ديسيبلينري ديسكشن بشوف الراجل ده هنعمل له انترفنشن ولا هنكتفي بتشخيص الهاي ريزوليوشن سي تي. This patient was assessed by a rheumatology consultant، واحد من التيم بتاعنا. A panel of investigations was required upon which he was diagnosed to have rheumatoid arthritis. لو اعتبرنا الهاي ريزوليوشن سي تي ديفينيت يو اي بي والعيان ده روماتويد ارثرايتس، تشخيص حضرتك ده يو اي بي اي بي اف ايديوباثيك فورم ولا روماتويد لانج؟ العيان ده شخصناه روماتويد لانج او يو اي بي secondary to. This patient is candidate for يعني من chest consultant او chest physician point of view. مجرد هنفولو اب العيان ده ونسيبه لدكتور الروماتيزم والمناعه يمانج، وانا مجرد بس افولو البيشنت ده كل 3 او كل 6 شهور، ولا انا ابتدي له سبيسيفيك therapy from the start. طيب هو according to our protocol العيان ده newly diagnosed rheumatoid arthritis زي ما هو برضه newly diagnosed interstitial lung disease. pulmonary function بتاعته كانت معقوله والعيان ده ما كانش بينهج قوي، فاحنا فضلنا ان العيان ده يبقى فولود بدكاتره الروماتولوجي، وهم طبعا هيبتدوا له سبيسيفيك ثيرابيز، لكن هيبعدوا عن شويه حاجات كده زي الميثوتريكسيت اللي ممكن تزود الانترستيشال لانج افكشن بتاعت البيشنت. واحنا مجرد هنفولو هيم every 3 or 6 months بكلينيكال اكزامينيشن وبهيستوري اسسمنت وبالمونري فانكشن وديفيوجن سبيرومتري اند ديفيوجن. لو العيان ده في خلال الفولو اب اول 6 شهور حصل ديكلاين في الاف سي اكتر من 10% وفي الدي ال سي او اكتر من 15%، حضرتك will start specific therapy for this patient yes or no. يس احنا هنتدخل start specific therapy for this patient، لان من خلال الفولو اب البيشنت ده كان بيديتيريوريت، فهندخل ب second line مع دكاتره الروماتولوجي وهنشارك معاهم في المانجمنت. هو ما فيش clear guidelines or recommendation for treatment of such patient with interstitial lung disease associated rheumatoid arthritis، ما فيش حاجه superior على حاجه. فسؤالي الثاني لحضراتكم which regimen will you start with؟ سايكوفوسفامايد، ستيرويد مع اذثايوبرين، الاميران ولا ريتوكسماب ولا any of the above؟ اوكي any of the above. زي ما قلت لحضراتكم مفيش clear guidelines، مفيش specific recommendation كلها against use of methotrexate and leflunomide for treatment of patient with rheumatoid arthritis associated interstitial lung disease. Do antifibrotics have a role in the treatment of this case? Maybe or no? Maybe yes. Maybe yes, maybe no. ايوه. يس دلوقتي الرول بتاع الانتي فايبروتكس بدا يزيد وبدا يكستند بياند اليوز في الايديوباثيك بالمونري فايبروزس، وبدانا نشوفه زي ما حضرتك قلت يا دكتور محمد في معظم البروجريسيف فايبروزنج انترستيشال لانج ديزيز. دي شفت حضرتك السلايدز دي قبل كده. الاذر كونديشنز اللي هي الاسوشيتد مع اليو اي بي زي الاسبستوزس وزي الساركويدوزس وزي الهايبرسنسيتيفيتي نيومونايتس والحاله بتاعتنا الروماتويد. As compared to UIP IPF, this prognosis or the prognosis of this patient is better or worse? Yes, survival and prognosis is better in patient with secondary UIP more than patient with idiopathic form of UIP. الكيرف ده بيبين لنا ان السرفايفل بيبقى احسن في العيانين اللي هم الروماتويد اسوشيتد او الكونكتيف تيشو اسوشيتد انترستيشال لانج ديزيز سواء يو اي بي او ان اس اي بي عن العيانين الايديوباثيك فورم اوف يو اي بي. طيب وبشكر حضراتكم.
شكرا دكتور محمد، وبالتالي كان اوبن للدسكشن لو في حد عنده اي اسئله. دكتوره ماري، هو البروفيسور مارتن معانا ولا he's with us؟ بروفيسور مارتن, do you hear us?
Yes, I hear you. Hello.
Hello. How are you, Professor Martin?
I'm good. How are you?
I'm fine, thank you.
Greetings to Egypt. I'm in clinic here.
So we'll take out of your time just a couple of minutes.
Yeah,
we won't disturb your practice. And let me ask you a quick question.
Mm-hmm.
If you're facing and you're having a patient with UIP and he got an exacerbation, okay, with a decline in his DLCO and pulmonary function and 6-minute talk test.
Yeah.
And he is on antifibrotics, you name it. He's on nintedanib, Ofev, whatever, or perfenidone. Do you still don't give him any steroids? I mean, he's declining, he's tired, he's on low flow, on long-term oxygen therapy, and he's still declining.
So
what
does this patient have an exacerbation or a steady decline?
No, it's an exacerbation.
Okay, so for exacerbations, the general approach is still to treat patients with steroids.
Oh, that's the
recommendation against steroids is really in regard to long-term high-dose treatment with steroids that we have done in the past. If you have a patient with exacerbation, most people would still give a steroid pulse, and that ranges anything between 1 gram intravenous for 3 days, followed by a relatively quick taper over 2 to 3 weeks. If this patient is not in the hospital, you can also give a high dose oral, like 2 milligram per kilogram, like 100, 150 milligram for 3 days, followed by a taper. But you would not give this long term. Yeah. So when I say a quick taper, it would be like over like 3 to 4 weeks. That's what most people would do around the world. But the recommendation against immunosuppression is really in regard to what we've done like 10 years ago and earlier, where people got a higher dose of prednisone with azathioprine for long term. That's been shown to be harmful.
By the way,
the one exemption for steroids is really when you give it as a supportive treatment. So a small dose of prednisone sometimes helps people with their cough. It can help them just like with general well-being. Probably has nothing to do with the lungs, but if you have an elderly person and the joints ache and hurt, they sometimes just have quality of life by taking their joint pains away with a small dose of prednisone. But we'll talk about 10 milligrams a day or so. Okay.
So you're talking about 10 milligrams.
That would be, but for symptomatic therapy, right? But if you ask about exacerbation, yes, we give typically a pulse dose of 1 gram per day for 3 days.
And then you taper. Because we see a lot of patients, they do improve at least subjectively. I'm not saying objectively. Subjectively, they tell you that they improve even with a minimum dose of 10 milligram, and sometimes even we give the 10 milligram on every other day, not on a daily basis.
That's I agree. So but that's not the dangerous dose of prednisone, right? So where the guidelines said it's dangerous based on a lot of evidence is when you do doses of 20 and 30 milligram chronically for many months, right? That's the dangerous stuff. But yes, I agree with you that sometimes patients on 10 milligram, they feel better. But I think it's not the lungs that feel better. It may be a bit concomitant airway disease, but often it's that the aches and pains that come with osteoarthritis and other joint discomfort is getting better, right? So that's why they subjectively feel better. And I agree with you that if you have a patient whose life expectancy is just a year or two, you have to really put a lot of effort on symptom management as well.
Thank you.
Professor Martin, I do thank you very much for your contribution. Just now you confirmed our short discussion with my colleague, Professor Tarek, about the role of corticosteroids. Because from our long experiences with the management of cases of interstitial lung diseases, already we see many cases improved, as Professor Tarek mentioned, not on the radiological or pathological lesions, but definitely there is some improvement with clinical manifestations and the quality of life and the symptomatology of the patient. That's why always we look to the recommendations by certain societies. There is no effect of corticosteroids, which is not true. Because if we correlate what is mentioned by the recommendations of different societies and on practical issues, there is some improvement with corticosteroids. And as I mentioned a few minutes ago with my colleagues, we have many diseases. Some of them are preventable, some of them are treatable, and some of them are not curable. But also, I want to ask you a very important question, that is there is some cases of interstitial lung disease is preventable cases or not?
So if you look at the whole group of interstitial lung disease, absolutely, right? So, I mean, our focus today was IPF. And for IPF, we know that steroids don't change the course, but they may change how patients feel at a low dose. So we are in agreement here, yeah? But they wouldn't change the course of the disease. There are other fibrotic interstitial lung disease where steroids have an important role. Organizing pneumonia, of course, hypersensitivity pneumonitis, certain autoimmune diseases, connective tissue like myositis. Those are disorders where immunosuppression is certainly helpful and should be considered, even if they are in the progressive phase, right? So, as I said, this was not our topic today, but we see these patients. If you have a patient with organizing pneumonia who has a progressive fibrotic phenotype, you may need to treat it with anti-inflammatories and antifibrotics at the same time, right? So, but it's not that. So it's neither true that immunosuppressants are everything we need, nor is true that antifibrotics is everything we need. There are patients who have both, right? Just look at people with heart failure. Yeah, you may treat heart failure in a patient with heart failure with diuretics, but if the underlying problem is coronary artery disease, you need to treat that too. Yeah, so and in fibrosis that's progressive, you need to treat the progressive fibrosis, which is antifibrotics. And if inflammation is the part of the problem, you need to treat with anti-inflammatories, which would include steroids in many of the ILDs. Yeah, so you're totally correct here.
Yes. The other issue, as I told you, about the prevention, because there is some cases of interstitial lung disease induced by certain drugs or certain occupational exposure or environmental changes, etc., so that if we can detect the cases in very early stages and we interfere as much as we can, as quick as possible, we think there is many cases which can be reversed completely with treatment and abortion of the underlying cause.
Yeah. There are. I mean, in different regions of the world, you have more exposure driven diseases than in others. Yeah. So, but yes, absolutely. So hypersensitivity pneumonitis, the causative agent is often difficult to explore. Occupational lung disease, the causative agent is often difficult to prove. But I could not emphasize enough that it's very important to make a correct diagnosis. Yeah, even in the era of having antifibrotics, because they help to prevent the decline in the patients who are fibrotic. But there are still patients where you need to put effort in and identifying the cause and counseling and avoiding it. Yeah, absolutely. So interstitial lung disease, as you will agree, is not, you cannot do that as quickly as managing a patient with common asthma or COPD. It takes a lot of effort and time. You need to make sure that your patients know that you need time, right? Because I always say we as doctors collect clues to solve the case. And these clues may sometimes be given at the first consult, but it takes sometimes a year or two to get enough clues. Yeah, I mean, you've seen that all, right? So it takes a lot of time and effort, and that's, I think, the interesting part of interstitial lung disease.
Thank you very much. You guys have some time for more questions?
Yeah, just ask some more questions, yeah?
Well, I'm going to ask another question, a quick question, and it's a quick answer. Do you prescribe the OFEB lintidenab for other fibrotic lesions? And to continue the question, it should be when you prescribe it, you go through the multidisciplinary discussion, and is it easy to buy this or to be given to the patients, or you need logistic approaches and paperwork, except because it is an expensive medication?
Yeah.
So what's the situation?
So you're correct. So I can only speak about Canada now in detail. So OFEB is approved for this condition. Canada has a public payer system. So when you live in Canada as a resident, you will be covered by public health insurance. And that is not yet covering the drug, but this is just logistical, right? So because it's been approved 1.5 years ago, usually it takes about a year for the payers to agree that they cover it. But COVID has slowed us all down. But we can use it. So if someone can afford it, we can prescribe it. Now, I think it's been approved in Egypt. I don't know for sure, but I thought it was approved for non-IPF. Is that correct?
It is, yes, but it's still a lot of patients. It's out of pocket. They buy it, and it's very, very expensive.
It's expensive, yes. So,
and we're trying to push this to be paid by the government. This is another regulation.
So it's very similar to Canada now. But
we started to implement the national insurance system. Yep. It's already now covered about 52% of population. And I think within the next 7 years, we will cover 100% of our population.
Yeah, that's great, right? So, because, this medication is really helping a lot of people, right? So, if I look at our clinic and at all the special clinics in Canada, because we have a big registry, about a quarter of the patients that we see in these clinics would be patients that benefit from this drug, just like IPF. So it's a big group of patients out there. But you asked about the MDD, which is very important to give you enough confidence, right? So if you are an expert and you've seen a lot, you are very confident in making a diagnosis, but you need many, many years to be such an expert. And even we at an expert center, we have our MDDs, and this is where you learn and where you make decisions much more confidently. What you want to avoid is to give this drug to the wrong patient, because that makes a bad flare, right? So MDDs, if you have it, is always valuable.
Concerning the players, I like your T-shirt. It's a red one, and I'm one of the fans of our national team of football in Egypt. And you're wearing one of the national team of Egypt. Sorry,
do I? Okay.
Zamalkawi. The other opponent is the Zamalek. So I'm a national with the national team. I think the Minister of Health is to agree with me. So thank you for being with us. I will invite you to have, what's the time now in Ontario?
11 in the morning.
So you can have breakfast with us now. We're going to have dinner now. That's late breakfast. Thank you very much.
I look forward to come and visit Egypt after COVID.
You should do it, and you'll be our real honorable guest. Thank you very much.
Okay.
Thank you very much.
Okay. Enjoy your dinner.
شكرا. شكرا جميعا، وبنشكر بورينجر وبنشكر ميري ومريم ومريان وكل التيم.
3M